Mira. I'm a professor of medicine at the University of Chicago, and I want to welcome everybody to the 15th annual Chicago Diabetes Day. And as everybody is sort of beginning to file in, we're going to have a fantastic series of presentations today, and I'm really delighted that you could all join us. A couple of things today. We are using the webinar function of Zoom, and that means that participants can't actually jump in and ask questions. And so what we're going to ask people to do is use the Q&A feature of the Zoom to input your questions. And then at the end of each of the presentations, I'll be the one that will read out some of the questions. And we probably won't be able to get to all of the questions, but what we will do is get to some of them, and then hopefully the speakers themselves can answer those questions on the Q&A feature. As I said, my name is Raghu Mirmira, and I'm a professor of medicine at the University of Chicago. And the 15th annual Diabetes Day, Chicago Diabetes Day, is hosted by the Diabetes Research and Training Center, the Chicago Center for Diabetes Translational Research, and the Kovler Diabetes Center at the University of Chicago. Today, to open our Diabetes Day presentations, I am delighted to introduce Dr. Seth Berkowitz. He is an assistant professor of medicine in the Division of General Medicine and Clinical Epidemiology at the University of North Carolina School of Medicine. Dr. Berkowitz obtained his MD degree from UNC and then did the primary care internal medicine residency track at UCSF, and later earned a master's of public health degree from the Harvard School of Public Health while serving as a fellow in the Harvard Combined Fellowship in General Internal Medicine and Primary Care. He performs research on population management, food insecurity, cost-related medication underuse, and the impact of adverse social circumstances on chronic disease management, particularly with regard to diabetes and other cardiometabolic diseases. His goal is to develop interventions and care delivery models that address social and economic needs as part of chronic disease management, and then evaluate these for both effectiveness and cost effectiveness. So today we're really excited to welcome Dr. Berkowitz as our opening keynote speaker at Chicago Diabetes Day. Dr. Berkowitz?
Great, thanks so much. Let me just pull my slides up here. Okay, hopefully that is sharing okay. Well, thanks very much for the kind introduction, and I'm excited to be here with you guys today. People in Chicago have been really key collaborators during a lot of the research that I've done, and I look to a lot of the work being done in Chicago as inspiration for the work that I'm doing here. I'll start off just by mentioning disclosures. I have no conflicts to mention. I have received research funding from the listed organizations and received personal fees about food insecurity research topics from the Aspen Institute. Just to kind of level set and give you a sense of how I think about these issues, although there are many ways to think about them. I'm going to start by distinguishing between social determinants of health and health-related social needs. These are related, but I think distinct topics. The social determinants of health, and people have probably seen either this definition or a similar definition before. This is the World Health Organization definition, but it can be thought of as the conditions in which people are born, grow, live, work, and age. I won't read the full definition here. But the key thing I think to mention is that these are sort of macro level forces. They shape the distribution of health in a society broadly. And you could think of key factors or key elements of the social determinants of health as the political economy in a given society, social policy that government at various levels may introduce, tax systems, things of that nature. The important point to recognize is that the system of social relations that we live in helps to determine the overall level and distribution of factors like poverty, food insecurity, diabetes, and the way that these intersect. Social determinants of health are definitely modifiable, typically through policy. They're often not, in my opinion, modifiable through clinical medicine. And so even though we'll sometimes talk about addressing social determinants of health as part of our clinical care, I think what we're actually doing might be better thought of as responding to what I'm terming here health-related social needs, have also been called social risk factors or things along these lines. The distinction there is that what we're responding to, the health-related social needs, I think of as individual level social and material factors that influence health. In a lot of ways, you can think of these as just sort of the basics that people need to stay healthy: food, housing, transportation, medication, social support, things of this nature. And so these are linked to the overall social determinants of health because the social determinants of health help determine the distribution of these factors. Why is the level of food insecurity what it is in a given society? Why do the people who are food insecure in a given society become food insecure, and why do others remain food secure? So those are sort of the social determinants factors. And then in clinical medicine, I think what we're responding to is the individual level expression of these. Now that someone is food insecure, or now that someone has housing instability, what can we do to improve health? So that's just kind of to give a overview of how I'm thinking about these factors and the terms that I'm sort of using here. When health-related social needs go unmet, the result is in poor health. And I think food insecurity is a key health-related social need across many conditions, but for diabetes in particular. Food insecurity can be thought of as inadequate access to enough food for an active, healthy life. A major driver of food insecurity are financial constraints. There are also issues of neighborhood food access, mobility, food supply, transportation, and things of that nature. It's important to recognize that though food insecurity and poverty are clearly correlated, they're not exactly the same thing. So poverty refers to, or whether someone is above or below poverty refers to a set level of income. Food insecurity I almost think of as more of a functional measure. It says, given your current financial resources or the social situation that you're in, are you able to meet this need? And so there may well be people with income levels that are below a poverty threshold, yet are still able to meet their food needs. And there are people with income above a poverty threshold, but are unable to meet their needs because of the specific circumstances they're in. And so again, while these factors are correlated, they're not exactly the same thing. And food insecurity sort of reflects the capabilities that people may have in their certain circumstances or lack of capabilities. Pre-COVID, about 1 in 6 individuals with diabetes were food insecure, and this worked out to about 5 million individuals in the US, so it's not a small number. This is about 1.5 to 2 times higher than the national average. During COVID, in the population overall, there was about a 1.5 times increase in food insecurity at the height. Fortunately, food insecurity seems to have been declining, but at its worst, it was about 1.5 times what it was pre-COVID. And this meant that from around 37 million Americans up to around 54 million Americans experienced food insecurity at some point in 2020. I haven't seen specific information for people with diabetes, but you would expect the pattern is similar in terms of the increase on a baseline that was higher to begin with. So likely saw an increase in food insecurity among people with diabetes in the last year. For people with diabetes, food insecurity is associated with worse hemoglobin A1C control. On average, across a number of studies, food insecurity is associated with about half a percentage point to 1 percentage point higher hemoglobin A1C, or if you use one sort of dichotomous indicator of glycemic control, whether A1C is above or below 9.0%, you see about 1.5 to 2 times the odds of glycemic control. Using this metric such that glycemic control is worse in people with food insecurity. And this figure represents some data from NHANES that is getting a little old at this point, but the things haven't changed that much. Food insecurity is also associated with worse blood pressure and LDL cholesterol in people with diabetes, and so really is associated with a number of cardiovascular risk factors that help determine outcomes for people with diabetes. Likely for these reasons, we see that food insecurity is associated with both microvascular complications of diabetes, including chronic kidney disease and retinopathy, and macrovascular complications, including coronary heart disease, congestive heart failure, peripheral arterial disease, and stroke. Food insecurity disproportionately affects racial ethnic minority individuals and individuals with lower socioeconomic status. If you look for racial ethnic disparities, you see that between non-Hispanic white and non-Hispanic Black individuals, the rates of food insecurity are about 2.5 times more in non-Hispanic Black individuals and about twice as high in Hispanic compared with non-Hispanic white individuals. And if you look by educational attainment, those without a high school diploma also have increased prevalence of food insecurity compared with people with a college degree or higher, and all these numbers are specific to people with diabetes. So these are differences we see within populations of people with diabetes. For these reasons, I think food insecurity is one pathway, although certainly not the only pathway for disparities in diabetes outcomes, and so I think it's important to address for health equity reasons. Important to note that food insecurity does not occur in isolation, as I mentioned, is clearly correlated with lower income, is correlated with other health-related social needs like housing and transportation and other adverse social circumstances like social isolation, and these are all important to consider, particularly interventionally. However, in terms of looking at the associations between food insecurity and poor outcomes in diabetes, we see that those associations persist even after adjusting for some of these other factors. And in fact, in path analyses, people have estimated direct effect of food insecurity on hemoglobin A1C, even when considering multiple other factors like income or other health-related social needs. So I really think this points to food insecurity being an important target for diabetes management in order to improve health. How does food insecurity, relate to poor outcomes in diabetes? I think there are at least three sort of evidence-supported mechanisms that can help explain this association. First, and probably the one that seems most salient or jumps to mind most readily when you hear about food insecurity, is a nutritional pathway. The basic way that this works is that when you face food insecurity, you sort of have constrained dietary options based on the financial resources available for you. You're likely to try to prioritize foods that are cheaper on a per calorie basis than other foods. And these are often things that are highly processed, that may have high sodium, high saturated fats, refined carbohydrates, and you're less likely to purchase things like fruits and vegetables, things with plant-based fats, things that are higher in fiber, et cetera. This likely has a direct effect on glycemia and also has an indirect on glycemia through being obesogenic and increasing body weight, leading to increased insulin resistance. Other pathways, though, are very important too. So another pathway that I think is quite important is something that I've termed here the compensatory pathway. This reflects things like food and medication trade-offs, or trade-offs between your ability to focus on your diabetes management when you're trying to, say, put food on the table for your children. The food and medication trade-off is sometimes called a treat or eat trade-off, where people report having to choose between filling their medications for a month or purchasing food. And so what you see here is that even though it's not directly related to the food or nutrition choices, there are ways that experiencing food insecurity plays out for diabetes management that have significant effects on it. And finally, there's an important psychological pathway. Food insecurity is a highly aversive condition. It's associated with an increase in depressive symptoms, more stress, more diabetes distress. It's associated with lower self-efficacy. And I think all of these combine to make diabetes management harder and have its own psychological impact on diabetes outcomes. A quip that I sometimes use is that when I started studying food insecurity, I thought it was all about the foods or the nutritional pathway. And the more and more I've been doing it, the more I think that a big piece of it is really the insecurity, the compensatory mechanisms, the psychological distress that the situation produces. And this is important because what it means is that even if food insecurity is not necessarily changing your diet, even if you're able to, cope by using various coping strategies to preserve the diet that you would have had otherwise, it can still be having important effects. And so though it's important to look at diet, we can't only look at diet when trying to understand the role that food insecurity may have on poor health, or when trying to intervene on food insecurity in order to improve health for people with diabetes. Food insecurity undercuts the management of type 2 diabetes in key ways. I mean, if you think about how we manage type 2 diabetes, you basically have, lifestyle measures and medication. When you experience food insecurity, it makes diet modification more difficult because you have these constrained dietary options. It makes weight loss more difficult for similar reasons, and because it's difficult to implement lifestyle change when you're worried about a lot of other factors, particularly basic needs like food. It reduces adherence to medications through the treat or eat mechanism that I mentioned. And so it kind of gets at both of the key ways that we use to manage diabetes. I think it also, is important to think about this as something that saps the bandwidth needed for self-management. If you think about what we ask people to do in diabetes self-management, it's fairly intensive, right? You may have people with fairly frequent monitoring of blood glucose, making lifestyle changes, increasing exercise, medication adherence, coming to various visits, maybe not just with a primary care provider, but also with specialist providers, with nutrition providers, et cetera. And so all of these things take mental effort to do, and it's hard to fit that in the midst of worrying about basic needs like food. Finally, I think it's important to note that food insecurity likely makes diabetes management riskier, particularly with regards to hypoglycemia, as people's food intake may fluctuate over the course of the month, but the dose of their diabetes medications may not. If those medications are ones that increase the risk of hypoglycemia, which can include things like sulfonylureas or insulin-based therapies, the risk of hypoglycemia goes up, and we see this consistently in people with food insecurity, that they have a much higher risk of hypoglycemia than we would expect based on either their A1C level or their duration of diabetes, or other factors that might otherwise predict hypoglycemia. So it's an important safety issue for diabetes management as well. So I think the relationship between food insecurity and poor type 2 diabetes outcomes are clear, but what's less clear is what to do about it. Fortunately, I think we're in a very exciting time where there is a lot of evidence being generated now and over the next several years. So I think we'll get much more clear answers. The flip side of that, though, is that at present time, I don't think we know, a single definitive strategy that works best in these cases. Some commonly proposed strategies include what are sometimes called screening and linkage interventions, where you might screen for food insecurity in clinical settings and then link people to clinic and community resources to address it, community health worker interventions, medically tailored meal interventions. And I should note that there are other types of diabetes intervention strategies that likely address food insecurity indirectly, even if it's not listed as a focus of the intervention itself. So for example, peer support interventions, which have been very successful, likely include elements of people supporting each other through difficult circumstances like food insecurity, and so may be influencing food insecurity even if they're not expressly designed to do that. Screening and linkage interventions, I'll spend a little time talking about because I think these are the most common and probably the most popular type of intervention currently. The probably largest example of this that I know of is an initiative through CMMI, Centers for Medicare and Medicaid Innovation, called their Accountable Health Communities model. And so this has approximately 30 sites across the country doing large-scale screening and linkage interventions for Medicare beneficiaries, not necessarily explicitly focused on people with diabetes, but with a large proportion of people with diabetes. Sites are screening, on the order of 75,000 people over the course of the intervention per site. So very, very large scale study. And so I think we'll learn a lot from that. We have in Chicago, you guys are fortunate to have really a sort of pioneering and groundbreaking example of this approach from Dr. Lindau's group and through the NowPow program. And I know you'll hear from her today, maybe not necessarily on this topic, but there's been great work done on this in Chicago. And there are a number of other organizations across the country that have done this as well. I think a key point to make about these types of interventions is that their success hinges on what I call the resource landscape. So what resources are available to refer people into. In the US, overall, we have a very local basis of resources, meaning that what are available in one area may not be available in a different area, and that there's large variation across areas. And so that's critically important to consider. And what I think to some extent this means is that local context is really key for these types of things, and you may not get a single definitive answer like these interventions work or they don't. It'll really depend a lot on the specifics of the situations in which they're implemented to understand what their true effects are. A key thing that comes out of screening and linkage interventions is the need to screen. And so I thought I'd spend a little bit of time talking about how to do screening and some issues related to that. If you're screening, I think one of the best ways to do it is to use what's sometimes called the hunger vital sign, which is a 2-item screening for food insecurity. These are the questions listed here. This is well validated in a number of different populations, a number of different formats, a number of different languages. And so I think is, it's obviously very brief being a 2-item measure. And so I think is a very good way to screen for food insecurity if you are going to screen for it. And I'll note that the American Diabetes Association now does recommend screening for food insecurity in people with diabetes. I actually have some mixed feelings about that, which I'll talk about in a second. But if you are going to screen, I think this is the way to do it. If you're only screening for food insecurity, the hunger vital sign is great. If you want to do a little bit more of a comprehensive screen, for example, screening for food and housing and transportation and other important social situations, there are a couple other tools. I've listed 2 commonly used ones here, but there are 10 or more ones that are all perfectly good ones to use. 2 commonly used ones include the Prepare toolkit, which is commonly used in federally qualified health centers, and the tool that's associated with the Accountable Health Communities model, which is called the Accountable Health Communities Screening Tool. And so there are links there if people want to look at more comprehensive screeners. But again, there are a number of other ones that you might use. When thinking about food insecurity screening, I think it's important to recognize that the same principles that we would apply when evaluating whether we should screen for any particular thing should apply for food insecurity here. Those include questions about what do we do with the information, particularly if we have a positive screen, how do we respond to it? What are the balance of benefits and drawbacks of screening? What are the competing demands or opportunity costs of screening? And what's the interval for screening? Should we screen everyone every time we see them? Food insecurity can change quickly, so that might argue for that. On the flip side, many people are stably food secure, and so maybe only a 1-year interval or something like that is reasonable. And these wind up being, I think, somewhat unanswered questions right now. Currently, we do know that screening can be done sensitively and patients are okay with it. People often worry about the harms of screening, and it is important to consider those. But when asked empathetically, asking about food insecurity does not seem to be off-putting for patients, and often in both quantitative survey studies of people who've been screened and in qualitative analyses, people report that it actually can help increase the therapeutic bond between the provider and the person being screened. A common way of framing it that I think is useful is, saying we ask because we care. We understand that these social circumstances are highly influential to how you can manage diabetes, and so we want to know that information to come up with a plan that works for you. Right now, I would say it's unclear that there are clinical benefits in terms of, sort of a universal screening program. So sort of asking everyone, regardless of circumstances or other things. And that's why I said I had sort of mixed feelings about a recommendation to implement wide-scale screening when we don't know exactly what the benefits are to that, if any. However, I do think it's important to distinguish between what I'm calling screening and assessment here. So even if screening is not indicated for everyone, i.e. that we don't necessarily ask everyone regardless of their circumstances all the time, assessment of food insecurity as part of formulating a diabetes treatment plan can still be very reasonable. And in fact, you can use this information to contextualize your care and adjust treatment plans, even if you can't directly address food insecurity. And so I think that's important to recognize. So even if you have nothing to offer in terms of addressing the food insecurity directly, you can still do things like change treatment options based on minimizing hypoglycemia risk, if that's a concern, or choosing plans for monitoring. Say that people are experiencing treat or eat type trade-offs. Maybe the cost of diabetes glucose test strips is prohibitive for people, or they're spending a lot of their resources on test strips. Maybe you can adjust treatment and plans in ways that don't require as much self-testing or monitoring in that way. And so this information, I think, can be useful for contextualizing care, even if we don't know in terms of screening, that we should ask everyone, and even if we don't feel that we're able to directly address food insecurity, which I don't think anyone would expect that clinicians one-on-one in an encounter would directly address food insecurity. Nevertheless, you can still make use of this information in important ways. After screening, what are some resources you can link people to? Assistance with SNAP enrollment, I think, is a very useful one, and there are many organizations across the country that can do this. Food pantries can be very useful, and fruit and vegetable prescription programs that can be useful as well. These often take the form of vouchers or subsidies that can be used to purchase healthy foods, either at farmers markets or sometimes participating in local grocery stores and things like that. And so that's another area that people are looking into and maybe a useful resource. SNAP linkage interventions are ones that try to get people enrolled in the SNAP program if they're eligible and not currently enrolled. SNAP is the Supplemental Nutrition Assistance Program, formerly called the Food Stamp Program. It's the nation's largest anti-hunger effort. It's known to reduce food insecurity. There are questions, although I think evidence is coalescing around a particular answer to that question about whether it affects health and healthcare use, and that answer seems to be that it does affect it, and positively. Overall, there have been a number of studies in the last few years looking at whether SNAP use is associated with lower healthcare use and spending, and finds that it has. Two great studies from groups in Baltimore out of Johns Hopkins looking at food assistance and finding that it was associated with lower rates of nursing home admission and lower healthcare utilization amongst older adults. And then a study that I was involved in that looked at a national data set found that that SNAP participation was associated with lower healthcare expenditures amongst low-income adults nationwide using a nationally representative data set. Another type of intervention that people are often linked into are food pantries. I wanted to highlight a particularly important sort of larger randomized trial from Hilary Seligman and colleagues looking at the provision of diabetes self-management support and food at food banks amongst people who are food insecure. This RCT did find that there was improvement in food and vegetable intake and that it reduced food insecurity, but did not observe changes in hemoglobin A1C for people in the intervention group compared with the comparison group who just got usual care. And then the last sort of type of resource that I wanted to mention here are these fruit and vegetable prescription programs. These are ones that are often operated through what was formerly called FENI and now is called the Gus Schumacher Nutrition Incentive Program, or GusNet program by the USDA. These can increase healthy food purchasing, and I think there's fairly good evidence of that at this point. They may improve diet quality, and we don't yet have clear evidence on whether there's an improvement in diabetes outcomes. We haven't seen evidence that there isn't, but it just hasn't been evaluated yet. So this is an active area of research. So moving on from sort of screening and linkage type interventions, I wanted to highlight community health worker interventions. Overall, I think there's very strong evidence for community health worker interventions in improving diabetes outcomes, and they are one of those types of interventions that likely address food insecurity along the way, even if they may not specifically focus on it. This study I wanted to highlight here from Shreya Kangovi and colleagues at Penn showed important improvements across a number of diabetes outcomes, and in other studies has shown benefits in terms of healthcare utilization and cost using their model of community health worker intervention called the IMPACT model. And so I think this is a very important and evidence-based option for people with diabetes and food insecurity. Again, community health worker programs may not be billed as specifically addressing food insecurity, but certainly if that is an issue that someone who's working with a community health worker is experiencing, the community health worker works with them to help address that. And then the final type of intervention that I wanted to spend a little more time talking about, just because this is one that I've been working on a good amount in the last few years, is what I'm calling medically tailored meals. So these are home delivered meals that are tailored to the specific medical needs of individuals. You can think of them as akin to Meals on Wheels, but with an extra element of medical tailoring that is provided. This inherently combines both meal provision, but also some educational component, although the type of education can vary. It may be fairly minimal, or it may be sort of a full-blown lifestyle intervention program. And so there's a lot of variation in that. There are about 30 organizations across the US that provide medically tailored meals. And an umbrella organization that represents them is called the Food as Medicine Coalition. Many of these organizations were founded in the late 80s and early 90s as responses to the HIV epidemic before there were good treatments for HIV and specifically to combat AIDS-related wasting syndromes. As HIV care has improved, many of these organizations have expanded out to other conditions. And so now chronic cardiometabolic conditions, including diabetes, are a large proportion of the conditions that these organizations serve individuals. These organizations serve individuals with these kind of chronic cardiometabolic conditions, I should say. I think medically tailored meals are likely to be especially useful for people with diabetes because it really overcomes what I think of as sort of the largest number of barriers to type 2 diabetes management of any type of food insecurity intervention. It increases food access. So, it gets food to people, which any decent food insecurity intervention should do. But it also removes barriers to shopping, meal preparation, portion size, knowledge of healthy foods by providing, precisely the foods that we think will be most beneficial for people. You really sort of cut straight to the chase there. It also, I think, importantly, serves as a modeling role. So after seeing what these meals look like, it's easier for people to implement and enact these types of eating patterns going forward, even after the program ends, because they've had the experience of seeing what a healthy portion of foods are, what the composition nutritionally should look like, et cetera. I also think the education that's inherent in the medical tailoring is an ideal time for lifestyle intervention. And so there, in my mind, is likely to be a lot of synergy between, this period where meals are being provided and the ability of people to learn about, why are they being provided, what specifically makes these good for people experiencing diabetes, and how can we implement that going forward, even after the meal delivery period ends. We examined in a pilot study the effects of medically tailored meals for people with diabetes and food insecurity, looking at changes in diet quality, again, as sort of the intermediate outcome in this pilot intervention. So in a pilot study of a little over 40 people with type 2 diabetes with A1C greater than 8 and who reported food insecurity, we looked at this in a population with a mean age of 58, was about 70% women, and was about half non-Hispanic white and half either non-Hispanic Black or Hispanic. This was in the Boston area. And what we found was that medically tailored meals strongly improved diet quality. This study used a crossover design, so people either got meals for 12 weeks and then usual care for 12 weeks or vice versa. And when people were on meals, they had a diet quality score as represented by the Healthy Eating Index of about 40. When they're on meals, it was about 30 points higher of 70. For people who aren't familiar with the Healthy Eating Index scale, it goes from 0 to 100, with 0 representing low diet quality and 100 representing high diet quality. The national average is for people with diabetes on the HEI scale is about 50. And so what we saw was that in the off meals period, people were about 1 standard deviation below the national average. On meals, they were about 2 standard deviations above the national average. So it was a very large improvement. And to put it into perspective, food subsidy studies, vouchers to purchase healthy foods and things like that, produce improvements of about 4 points. So this was much larger than that. We also found that it significantly reduced food insecurity. It was associated with lower self-reported hypoglycemia and improved mental health-related quality of life as measured by the CDC's Healthy Days scale. Also, qualitatively, just talking with people, they reported less stress when managing their diabetes and a better understanding of diabetes-appropriate diets. This study was not designed to examine changes in hemoglobin A1C, but we did see, especially given its short duration and small size, but we did see suggestions of improvement, about a 0.4 percentage point change from baseline in the on meals period, although it was not statistically significant in this sample. That served as pilot data, leading to 2 larger scale trials that we're now gearing up for, where we'll be testing medically tailored meals for people with diabetes and food insecurity, one for patients with HIV and one for patients without HIV, but with diabetes and food insecurity in both groups. In addition to our study, there's a group in Philadelphia that has an ongoing medically tailored meal trial and a group in San Francisco as well. So I think we'll really get a lot more evidence about the effectiveness of medically tailored meal interventions in the next couple of years. Going forward, and as I'm sort of wrapping up here to leave some time for questions, things that I think will be important in the food insecurity space, other than the efficacy questions that are being currently investigated now, are understanding contextual factors. How do these factors, things like household composition, other health-related social needs, other food insecurity interventions that people may be participating in, affect the response to particular food insecurity interventions for people with diabetes? And in medically tailored meals specifically, how do things like variations in the structure of the program, the number of meals per week, the variation in the diets, the variation in the educational component, how do those affect the impact of the programs? I think also, if we're lucky enough, as I think we might be, to in the next few years get evidence that there are a couple of different interventional approaches that work, then we'll move from the sort of efficacy questions to the comparativeness, effectiveness questions. Which interventions work best in which case? Some individuals may do well with lighter touch interventions, food subsidies or linkage. These will generally be more affordable. They'll be cheaper on a per person basis than other things. And so if those work well for people, we should use them. Things like medically tailored meals may work well for some people, but these are more comprehensive and likely more expensive on a per person basis. And so we need to think about what the right situations to deploy those are. These are sort of analogous to heterogeneous treatment effects questions that emerge, I think, in many fields. And so this will be an interesting area to look at going forward. The last thing I wanted to touch on before ending is just to think about policies to support food as medicine. I think we all recognize in research that you often, if you're lucky and you have something that works in a research study, that's great, but how is that sustained afterwards? Does it end when the research program ends? Fortunately, I think the sort of food as medicine idea has been embraced by policymakers recently, and there are a number of mechanisms to support these types of programs if we can find ways of delivering it that really work to improve health. Medicare Advantage programs, since the Chronic Care Act passed in 2018, are able to offer these programs like medically tailored meals as benefits to people. So that's one way that they're supported. Medicaid's policy at state, particularly at the state level through 1115 waivers, is offering food as medicine type services now. The Massachusetts state plan calls these flex services and has a very large ongoing demonstration of this. In California, their Medi-Cal program has a medically tailored meal pilot after congestive heart failure admission. And in North Carolina, we have a 1115 waiver for what are called the Healthy Opportunities pilots, which will have a large focus on addressing food insecurity. This has sort of been on hold due to COVID over the last year, but is now back to ramping up. And so we're sort of excited to dive into that here. But we're looking to enroll something on the order of 30,000 people with health-related social needs amongst amongst Medicaid beneficiaries, and offer services for food, housing, transportation, and interpersonal violence that people may experience, and examine the effects on health utilization, and healthcare costs. So just to wrap up, key points I wanted to sort of leave you with are that food insecurity is associated with greater diabetes prevalence and worse diabetes control. Food insecurity likely worsens diabetes control through three key pathways: a nutritional, a compensatory, and a psychological pathway. Food insecurity assessment can be an important part of contextualizing diabetes care, even if you're not, as an individual, able to offer anything to address food insecurity directly. It still is important information to incorporate into your care plan. And finally, while still in its early stages, I think interventions to address food insecurity show promise as part of diabetes care. So I want to say thanks again for the invitation to speak with you guys. I think we have a little bit of time for questions, but if there's anything that we don't get to here, please feel free to send me an email. Thank you.
Wonderful. Thank you so much, Seth. That was fantastic. And there was really quite a bit of discussion on chat. We have a couple of questions as well. But can I just start off by asking, so you suggested earlier with screening that maybe it may not be appropriate for everybody, but for those of us who are clinicians and do see patients with diabetes, who should we be screening?
Yeah, so I mean, I think to one end, I think this is an unanswered question. I think in terms of one way to approach screening are situations where you think getting the information really may change what you want to do, and so there may be people who are not at a particular goal for a risk factor that you have. Their A1C may not be at goal, or you think that perhaps their medication adherence is suboptimal, and you want to investigate a little bit more about about that. You may also want to screen people based on other information that you may have about their circumstances. So for example, if you know that someone has housing instability, because that is closely correlated with food insecurity, that might be a good question to ask there. I think it's also important to recognize that we don't know exactly, we're not going to know exactly who someone who's food insecure looks like just by using demographic factors or insurance factors. We should only screen our Medicaid patients or something like that. That's not true. We know that people with private health insurance are food insecure. We know that the plurality of people with food insecurity in the US are non-Hispanic white individuals. And so sometimes people talk about only focusing on racial ethnic minorities for food insecurity screening. I think that's likely misguided and misunderstands the way food insecurity plays out in the US. So I think we have to take a nuanced approach while also recognizing that there's a fair amount of uncertainty, both as to who we should screen and also what that information does. Fundamentally, I think the key thing is the question that comes with all screening is, what are you going to be able to do something useful with the information once you get it? If you are, then by all means do it. It's unlikely to be harmful. It doesn't take a lot of time. But if you're not, then I think you have to be a little more circumspect about how that fits into the overall clinical encounter.
Right. Thank you. All right, we have a couple of questions on the Q&A. So Jessica Wang had a question regarding the MTM program, and she states that once people are prescribed a renal cardiac diabetic diet, people are frequently at a loss. It would be great, I guess this is more of a comment, it would be great to have multidisciplinary resources or collaboration with this regard to, I guess, the MTM.
Yeah, no, I think that's exactly right. I mean, I think we, if I'm interpreting the comment correctly, I think when we say people should follow these diets, we may say it as sort of an off-the-cuff thing, or think that it's very clear what that is, but often it's difficult for people to follow. It may mean a significant change in how they were eating. We eat as members of a household, and so does that mean that everyone is going to be eating that way, or are you going to have to be preparing special meals for you and different things for other people? And so that's why so I 100% agree that multidisciplinary approaches are important here. It should include education from nutritionist colleagues. It should include consultation amongst the medical team to understand what are the most important elements and how these fit together, particularly when people have comorbidities that sometimes have sometimes complementary but sometimes differing recommendations about what people should eat. And so I think that's really key. One reason I really like the MTM approach is it kind of boils all that down into a set of meals that people get, and so it's not just a list of things that you should or shouldn't do, but it's a practical demonstration of, like, here's what a healthy meal looks like for you given all your comorbidities, maybe not just diabetes, but diabetes and chronic kidney disease, and maybe you're on warfarin anticoagulation and so need a consistent level of vitamin K in your diet, et cetera, et cetera. It gives clear examples of that, and so I think makes it a lot easier for people to follow.
Sure. Okay, Marshall Chin had a couple of questions. First, he congratulated you on a great talk, but then he said, could you tell us a little more about how the state of North Carolina has become a leader in finding ways to support healthcare organizations address food insecurity and social determinants of health? And then also, why did North Carolina become a pioneer in this area?
Yeah, thanks, Marshall, for the compliment, and certainly the work that you do in Chicago has been a big inspiration for this. So it means a lot to me. I think the story in North Carolina is really a positive story of what political leadership can do. As people who aren't from North Carolina may not know, North Carolina is a fairly purple state. It's a southern state, but has a fairly progressive tradition amongst southern states, and the political leadership in North Carolina, on one hand, has maybe worked against health equity. We're not a Medicaid expansion state, for example, coming out of the legislature, but on another hand, has been extraordinarily progressive. And so on the side of the governor, and which runs DHHS, which is the Medicaid agency. They have been very progressive, and so in particular, the Healthy Opportunities Pilots program is, sort of purely the brainchild of leaders within DHHS, including Mandy Cohen and Betsy Tilson and Erica Ferguson, a number of other people who really recognize the need to address health more broadly than was previously being done. And then I also think the North Carolina is a good example of how partnerships within healthcare insurance organizations is very important. Blue Cross Blue Shield of North Carolina historically was sort of the major private insurer. The markets have opened up a little bit, but they had a huge amount of the private insurance market share for many years and are still, I think, the leading insurer. And they, as an organization, have taken this very seriously and are involved in a number of pilots and other sort of demonstrations and changes in benefit design to try to figure out how to do this. And so I think it really boils down to leadership, both on the political side and within sort of the major healthcare organizations in the state. And I think for this perspective of academics or people interested in policy, I think also points to the importance of building these sort of collaborations and partnerships in terms of both being able to hopefully influence designs and decisions and also be able to evaluate them and see what the real effects are to provide evidence to support the change going forward.
That's great. Well, thank you so much, Seth. I mean, we are, we're gonna try to stay on time here, and really appreciate your talk. That was really very interesting, and I think I'm really looking forward to your trial, the MTM trial. While we're on that, real quick before we move on, sure. You did point out that you were you had a couple of groups with and without HIV. How does HIV enter this, and why is that important?
Yeah, so I think one thing that's been interesting for me to learn as someone who hadn't previously done a lot of work in HIV is just how the confluence of HIV and diabetes risk that we've seen over the last couple of years. There are a number of explanations for this that are posited. One is just the aging of the population with HIV, given that we have more effective treatments now and people are less commonly dying from HIV-associated infections. And so as people get older, they're at increased risk of other cardiometabolic risk factors. There seems to be some influence on diabetes of the chronic inflammation of HIV, even when people have suppressed viral loads. And there also seems to be a specific contribution of both through inflammation and sort of adiposity pathways of particular types of HIV treatment, particularly integrase inhibitors, may be associated with some risk there. But all of the upshot of all of this is that people with HIV are at high risk for developing diabetes. When they develop diabetes, they're at high risk for cardiovascular complications of diabetes. And so it's really sort of an under-recognized area of diabetes risk. And so one that's been interesting for me to learn about, and we'll certainly be interested to see if these programs are helpful, again, given the confluence of HIV risk factors and social risk like food insecurity.
Thank you so much, Seth. Really looking forward to the outcome of that study. All right, so we're going to move on to our short talks now, and the next one that we have, there are actually going to be two speakers. So let me briefly introduce both of them. Our first speaker is Stacy Lindau. Dr. Lindau is a professor of obstetrics and gynecology and medicine at the University of Chicago, and a practicing gynecologist with expertise in preservation and recovery of female sexual function in the context of cancer and other complex illnesses. She received her MD from Brown University, her residency at Northwestern, and her fellowship at the University of Chicago. She directs the Community RX program of research, including several current clinical trials focused on how and why connecting people with their caregivers to community-based resources drives health and well-being. As well, we have Dr. Albert Wang, who is a professor of medicine and director of the Center for Chronic Disease Research and Policy, and associate director of the Chicago Center for Diabetes Translation Research at the University of Chicago. He's a member of the Professional Practice Committee of the American Diabetes Association, received his MD from Harvard, residency in internal medicine at Stanford, and then a fellowship at MGH. Dr. Wang is a general internist who studies clinical and health policy issues at the intersection of diabetes, aging, and health economics. His research has provided the evidence-based foundation for the concept of personalizing diabetes care goals, as well as the contemporary natural history of the disease in older people. So with that, I'm going to turn it over to Albert and Stacy.
Thank you very much. We're going to tag team here, and inspired by Dr. Berkowitz, we will move at a good pace. Next slide, please. Albert's the slide man. So as has been referenced, we have a large multidisciplinary team working on the My Diabetes, My Community program. And it strikes me just now that Albert appears to be the only man on this team. But we want to acknowledge this great group of epidemiologists, nurses, physicians, scientists, statisticians. And then my disclosure slide, which we're happy to, it probably is with the materials, comes from the Healthcare Innovation Award from the Centers for Medicare and Medicaid Services several years ago, which helped us to develop the community RX intervention, which is part of the trial we're describing today, and had as an expectation that innovators would develop a sustainable business model. As a consequence, I founded 2 business entities, and we're testing a collective social impact business model for sustainability of a technology that connects people to community-based supports. Dr. Huang and I collaborate in a couple of different areas, and we're excited to share this part of our collaboration today. Next slide.
So the My Diabetes, My Community trial is it's an interesting combination of a trial that addresses social needs in part, but also addresses kind of basic clinical research questions that we still have. The target population is people who are with diabetes who are over the age of 65. It's a very large proportion of the diabetes population, over 40%. They're clearly a high-risk, vulnerable population at the highest risk of all the complications of diabetes that we know, what we think about, but also at the highest risk of the side effects of our medications, namely hypoglycemia. And in the last year, they have been the group at very high risk for COVID-19 complications. So there's considerable uncertainty still regarding the role of intensive glucose control in older people with diabetes, especially people over the age of 75 and those with multiple comorbidities. I helped to write guidelines for the ADA in 2012 that recommended risk stratification goals based on health status. And to date, this protocol has actually never been formally studied, but this trial will do that. So the My Diabetes, My Community trial, it aims to address these knowledge and care gaps by integrating 2 evidence-based interventions designed to personalize glycemic control, engage patients, and enhance self-care. The My Diabetes Goal Intervention is designed to engage older patients in personalized goal setting and then chronic disease management with the help of a nurse. The Community RX intervention is a theory-driven and evidence-based community resource referral information system that Dr. Lindau developed and is iterated in partnerships with stakeholders across health and social care sectors and local residents. So the trial is going to study the combination of these 2 interventions. So our first aim is going to be just around patient experience and satisfaction around goal setting and communication, whether or not there's more documentation about goals in the electronic medical record. We'll be assessing patients' self-report of their own diabetes goals. So we think that the first aim will just be to just focus on goal setting. The second aim is going to be focused on whether or not there's any change in actual self-care, but both in diabetes self-efficacy and self-management behaviors, but also in whether or not their knowledge and utilization of community-based resources changes with the 3 different trial arms. And finally, we'll be evaluating the impact of the My Diabetes Goal and My Diabetes Goal Community RX combination on glycemic control, hypoglycemia, functional status, and healthcare utilization. This is a large 3-arm randomized controlled trial of over 600 subjects. 200 will be allocated to attention control, 200 to My Diabetes Goal alone, and 200 to My Diabetes Goal with Community RX as well. These patients will be followed for 12 months with 12 monthly calls, either done by research assistants or our research nurses, and with in the 3rd arm with additional access to Community RX. So during the My Diabetes Goal arm, This is the core intervention. This is a monthly nurse case management call. It begins with a formal conversation about setting A1C goals with the older person that uses 2 different kind of prediction models to guide the discussion. And during subsequent calls, when patients have decided on a goal, the nurse works with the patient to assess barriers and strategies to overcome things such as actually the social determinants of health that Dr. Berkowitz talked about, but also issues around diet, physical activity, medical comorbidities, and hypoglycemia risk. This is a snapshot of this. The nurse protocol has been developed into a very nice manual that will be reproducible and usable by others once this trial is done. This is just a snapshot of what the glucose goal setting discussion looks like for the nurse. It includes some of the principles that are guiding the discussion around partnership, information exchange, and shared decision making. I'll now pass this on to Stacy.
So I'll just talk a little bit more about the Community RX plus My Diabetes Goal arm of the intervention. And this is iterated from the Community RX intervention being studied in a few other trials and populations. The Gray self and family management model for chronic disease is the underlying theoretical framework for the intervention. It is a low intensity, highly scalable component of the overall intervention for this study. People will get some information, brief coaching. Many people living with diabetes benefit from community resources. And then individuals will be activated to know about and hopefully to use as needed community resources specific to their goals and needs. So this will be delivered in the format of what's called a Healthy RX, a printout of resources personalized to the person's home location and other needs. And then there will be boosting across these, across these encounters over the phone. And boosting means that the patient can get a new copy of their original Healthy RX or new Healthy RX or new resources as needed, as perhaps needs change over time. Next slide. Albert mentioned the attention control arm. I think this is an important aspect of the trial. We see other trials in the field with a control group, but without attention control arm. And given the amount of attention the intervention group will get, this is very, very important. So there are a number of topics, as you see at the bottom, that have been developed with best available evidence on these topics, selected to educate people about important topics related to aging, but not to go too far into diabetes-related topics. Next slide. We just wanted to quickly share an innovation that we're using to manage this trial, and we're using this, Albert and I are using this infrastructure for another trial as well. The REDCap database is being used to collect participant data together with Mosio, a text messaging vendor, and there are many out there. That was the one that worked best for our purposes. And now PAL, the community resource referral platform we're using, we have built APIs. So we have one infrastructure that allows us to collect participant data and then to drive our text-based communications and our community resource referral communications to patients. And this is an innovation that looks like it may even be useful to another trial we're working on in North Carolina with Dr. Berkowitz's colleagues. Next slide. Thank you so much. We wanted to leave a couple minutes for questions.
Okay, thank you guys very much. That's really interesting. You know, and we don't have any questions quite yet from the audience, but you know, Stacy, this brought up as I was listening to this, you know, a comment that you originally made, actually the first comment you made about at Seth's talk about distinguishing between, you know, sort of individual factors and those that might be imposed by the community, or, you know, sort of structural factors that may impact diabetes care.
Yes, thank you for that point. And I think well, I made that point just because, and I'm sure Seth made the point for the same reason, in so many, you know, SDOH has become a word. And when many of us started this work 10 years ago, 15 years ago, there was no such phrase. In many venues, that phrase, or SDOH, is, I think, being misused. And we run the risk of looking to blame individuals or look for solutions inside the bodies of individuals to social and systemic factors that drive health of populations. In the case of our intervention, of course, this intervention is individually focused. And so the diabetes education work and the community resource referral work does target individuals. But when we target individuals at scale in the routine workflow, we quickly generate data that can be used as evidence to drive those structural changes, to bring forth evidence to policymakers to say, look at how many people in our practice with diabetes are food insecure and have other health-related socioeconomic risks and needs. We can't solve all of these problems inside the four walls, but we need to solve these problems if we're going to get control of diabetes. And so it's that systematic, digitized, data generating type referral work that can quickly scale up and be used for advocacy.
Yep, great point, great point. Well, all right, we've got a few questions in the Q&A, so we'll see if we can get through at least a couple of these. So Siramon Truckle asked, how does diabetes treatment fit into the A1C goal setting?
So I'll answer that. This is primarily a lifestyle intervention, clearly, but one of the vehicles we think that will change people's glucose control is probably through greater medication adherence. We do have nurses involved in the trial, so they'll be intervening in two ways. One is we have a hypoglycemia risk prediction model built into the intervention that screens people at the beginning. If they're at high risk for hypoglycemia and they're on inappropriate medications, the nurses will be reaching out to the provider. Similarly, if a patient has a very ambitious glucose control goal and maybe a candidate for a new drug, the nurse will also drive that as well and interact with the care provider.
Right. All right, maybe we have time for one more, and I'm going to go to Neda Latirapong's question. Really exciting trial. How will the usual clinical care by PCPs, endocrinologists be considered across the three arms?
Well, go ahead, Stacy.
I was going to say, Albert.
Oh, yes, I can do that. Yeah, no, we recognize that there are changes going on. Hopefully randomization will help address kind of variation among PCPs and endocrinologists. There's a lot going on in the UFC system in terms of trying to encourage use of the newer classes of drugs. There's a diabetes quality improvement effort that I'm involved with Celeste Thomas. All of that will be happening in the background, and our intervention has to show an effect on top of all of that.
Wonderful.
So we have a high bar.
Wonderful. Well, thanks a lot. And I think Marshall Chin's question is being answered by Stacy on the Q&A. So we'll move on and sort of stay on time here. And our next speaker, we're going to kind of shift a little bit from the two talks you just heard to something a little bit different now. And so this is Dr. Daria Esterhazy. Dr. Esterhazy is an assistant professor of pathology at the University of Chicago, and she was selected to join the 2020 class of Pew Scholars in the Biomedical Sciences Pew Charitable Trust. She received her PhD from Switzerland studying pancreatic islet biology, did her postdoctoral fellowship at the Rockefeller University, and she investigates how immune equilibrium is maintained in the digestive system and how imbalances can lead to diseases such as food allergies, inflammatory bowel diseases, autoimmune diseases such as type 1 diabetes and cancer. So with that, I'm going to let Dr. Esterhazy take over.
Thanks a lot, Raghu, and it's a pleasure to speak as the first sort of basic scientist here amongst all these doctors. And so what I will tell you about is how we think that the duodenum might actually control pancreatic immunity through a very particular route, and that is through shared lymph node drainage. And so really our story starts in the gut, where we observed that along the intestine, not only are the draining lymph nodes, which are critical sites for adaptive immunity, compartmentalized, but they're also immunologically distinct, such that overall, the more proximal in the intestine you are, the more immunosuppressive these lymph nodes are, and the more distal you go, the more inflammatory they become. And so that's, of course, important in the context of something like food allergy prevention, where most of dietary antigen is drained to these upper small intestinal lymph nodes, and thereby, by default, food allergy is prevented. Now, we started to be interested in what really governs this duodenal environment up here, and started to ask, well, can you change this at all? And it turns out you can through gastrointestinal infections. And the way we study this on a very basic cellular level in mice is that we do what follows. We use the model antigen ovalbumin, so from chicken egg white, and then give them CD4 or CD8 T cells that recognize specifically a peptide from this. And then ask, what do these cells become? So on the CD4 T cell side, you can either become one of those immunosuppressive or tolerogenic regulatory T cells, indicated by FOXP3, or you can become a pro-inflammatory T cell. And so then what we do is we take all the lymph nodes that we know drain the gut in the mouse. Luckily, as opposed to the human, there's only about 10. In humans, there's more than 150. And then ask in which lymph nodes do we see a reaction? What kind of reaction do we see? And in addition, we can interfere with this by giving infections, for example, viruses. And so when you do this, this is what you see in a non-infected mouse. You see this gradient that I alluded to, proximally to distally. You induce more Tregs in the duodenum draining lymph nodes. And as you go down, this decreases. However, if you have a virus on board, this reaction is greatly abrogated. And sure enough, actually, this leads to food allergy. So that's the CD4 T cell side. We can do the same thing with the CD8 T cells. And here, at least it's less known what kinds of nuances there are, but by and large, you create cytotoxic T cells. And we can ask the same thing, what happens there? And here I'm showing it for two viruses. No matter in which lymph node you look, because this virus infects the whole intestine, you have way more cytotoxic cells recognizing dietary ova when you have the virus on board. Now, I would like to introduce this other very intriguing concept, and that is actually that these pancreatic duodenal lymph nodes, while unique to the duodenum along the intestine, are actually shared with the pancreas and some also with the liver. And of course, this is known to this audience. The pancreas includes two kinds of cells, the exocrine cells that produce digestive enzymes, and then about 5% of pancreatic islets that are critical for the glycemic control by virtue of insulin and glucagon production. Of course, it's the insulin producing beta cells that are the target of autoimmunity in type 1 diabetes. And so what this brings us to is this question of how does common lymph node drainage affects organ-specific immunity. So what happens if you have a duodenal infection in that lymph node? Of course, we know that in response to oral antigen, these become pro-inflammatory cells instead of Tregs. But the question is, the pancreas-derived antigen, what happens to that in the context of a duodenal infection? And so you can think of two scenarios. It could be that the infection in one organ creates a local milieu in the lymph node that's pro-inflammatory, so that the reaction to pancreatic antigen becomes pro-inflammatory also. Or alternatively, the lymph nodes could have a more passive role where a dendritic cell primarily instructed in the tissue of origin just does its job. And in that case, you'd be able to have an inflammatory reaction to the duodenum and a more benign reaction to the pancreas, unless you had pancreatic antigen going onto a duodenum-derived DC. And so what I'll tell you about today is just two little aspects of our story, and that is actually identifying which lymph nodes are shared in the mouse and which ones are pancreas draining. This was never systematically mapped. And then what actually happens to the T cells that recognize pancreatic antigen in the context of a duodenal infection. And so the way you would normally map draining lymph nodes, at least in the mouse, is you would inject dye into your tissue of origin and then just follow the dye to the lymph node. Unfortunately, in the case of the pancreas, that's not really possible because it's a very floppy discal tissue. So we use this imaging approach that I'm showing you here. So in red, you have the vasculature. In white, in a second, you will have the lymphatics. And our idea was to follow the lymphatic trees that you see all over here to the lymph nodes that are embedded in the pancreas. And here, lastly, in green, you have the insulin denoting the pancreas. Now, this was not quite obvious, but at least it allowed us to pinpoint potentially 4 lymph nodes, what's known as the celiac, the liver draining, the duodenal, and the ascending colonic lymph nodes that are so highly embedded in the pancreas and seem to have a lymphatic connection that were potential candidates. And so what we refer to next is a T-cell-based assay to determine in which lymph nodes do you actually do the T cells see antigen, because obviously these need to be the ones that drain the pancreas. And so we use 2 mouse models. One is the classical rhythm ova mouse. So this is a mouse that produces ovalbumin, so the same antigen as the oral antigen, under the rat insulin promoter. And in that case, we can use our CD4 OT2 cells, or we use NOD mice where we have CD4 T cells at hand that recognize endogenous chromogranin A. And then just ask in which of all these lymph nodes do we see reactivity? And gratifyingly, in both models, it was the same lymph nodes that popped up. And it was the liver draining, the celiac, and the duodenal lymph node, but not this ascending colonic lymph node that we, just by anatomy, could have predicted to also drain the pancreas. And to further substantiate that this is to do with antigen availability, when you kill pancreatic beta cells with streptozotocin, thereby releasing a lot of antigen, this reaction is increased. Right, so now we know in which lymph nodes to look. And yeah, this is just the map of the cold drainage, which is very interesting of its own, because we can actually now use this as a neat little system to ask what happens in the situation of cold drainage of organs. And so lastly, what I'm going to show you is how we address now what happens to pancreatic antigen in the context of a duodenal infection. What we do here is we give a virus. I should say we've done this in a couple of models. I'm just going to show you the 2 viruses. And then adoptively transfer, in this case, CD8 T cells, and we can talk if we have time later about why we chose that. So these are also, again, autoreactive T cells that, in this case, recognize IGRP. Then we boost a little bit, not with a high dose, but low dose of streptozotocin to have more antigen, and then harvest and look at differentiation. And so when we do that, this is for T1L, we see that specifically and only in the lymph nodes, and this is just 3 days after infection, we see 10% of the autoreactive cells becoming highly cytotoxic, whereas you see nothing. Basically, the blue line is nothing down here in this situation of no infection, and the same is true for MNV. And so what this implies is that the duodenal infection, so this does not infect the pancreas, is sufficient to elicit a cytotoxic response to an islet antigen because of this co-drained anatomy. And so that's what I've just shown you. So the ongoing questions that we now have are obviously, what is the mechanism of this duodenal impact on the pancreatic antigen response? Is this solely dendritic cell mediated, or is it another lymph node component? What is the consequence for type 1 or type 2 diabetes, but also for that matter, pancreatic cancer immunity, because that's then the exocrine pancreas. And more broadly, where is the bulk of the antigen loaded, and what matters more, the DC source or the immune outcome? And so we are addressing this actually now for the first time to our knowledge ever, where we're asking where the dendritic cells come from. Does that make a difference on what they look like in bulk, but also in single cell RNA-seq? And so we're asking now what effect the tissue of origin has on how you handle antigen and how this conflict basically works. And so with that, I would like to just thank the people in the lab who've been doing this work, a PhD student and a technician, and I'm still a lot on the bench as well. I would like to thank the whole University of Chicago, in particular also the DRTC for supporting in a pilot and feasibility grant, and support from colleagues and the course. And with that, I'll be happy to take questions.
Thank you so much, Daria. Very interesting work. We don't have any questions yet, but so I'm going to start. So, one of the sort of controversies in the area of type 1 diabetes is this idea of, viral infection. And in that regard, what a lot of people have been focusing on is viral infection of the pancreatic islets themselves, which is where the controversy arises, because we really don't, some people would say there's evidence of it, some people say there isn't, but your hypothesis really kind of sheds a different light on that, because what you're suggesting is that it's really more, duodenal infection by the virus and not so much the pancreas infection. Right?
So I don't know if it's one more or the other. What I'm saying is you don't even need the pancreas to be infected.
Right.
It suffices to have the duodenum to be messed up. Yeah.
That's really very interesting. Okay, well, we have one question on the Q&A. Have you also tested whether the inflammatory response is affected in the liver, and do these lymph nodes drain to the visceral fat too? Yeah,
that's a very good question. We haven't done the liver route yet, really for the lack of very good models that work in mice. Yeah, so we'll probably go in the direction of NASH and that kind of thing to have sort of a liver impact and then see whether we change. And that's a very good question. The visceral fat, to my knowledge, is not drained by these lymph nodes, but I wouldn't know specifically. Yeah.
Okay, another question. Do any nodes have more than 2 organ connections?
More than 2 organ connections?
Right.
Yes, the celiac lymph node is all 3, is liver, pancreas, and duodenum.
Interesting. Okay, great. Well, if there aren't any more questions, Daria, that was great talk. Really great technology as well, and I think very insightful. Thank you very much.
Pleasure.
Yeah. All right. So now we're going to move on to Lisa Butler, who is an assistant professor of medicine at Northwestern University. She got her MD and PhD degrees at the University of Washington, did her residency and fellowship at UCSF, and there we share a connection, Lisa. And then she studies the understanding of how the gut and brain communicate with each other to maintain body weight and how this goes awry in diseases such as obesity. Her team uses a variety of techniques, including optogenetics and calcium imaging in genetically modified mice. So Lisa, really looking forward to hearing your talk.
Thank you, Raghu. So thanks for the really nice introduction. I'm excited to be here to tell you a little bit about my work that I've started in my lab, which opened in July of 2019. So kind of emerging from the pandemic with some exciting new data. Disclosures, I own a trivial amount of Eli Lilly stock and won't be discussing any use of any drugs. So I don't think I need to belabor to this audience that energy balance is tightly regulated in healthy animals, and mammals are exceptionally good at maintaining their body weight. And at the most basic level, this occurs by balancing food intake and energy expenditure, which when you look at some older population studies, and do some back of the envelope calculations, you come to the conclusion that a huge chunk of the population is able to maintain their energy balance within about 6 kilocalories per day. And to put this into perspective, that means that about half of the human population is able to balance their food intake with their energy expenditure within about a quarter of a cup of broccoli, within less than a teaspoonful of macaroni and cheese, and within about a minute of light jogging, day to day, year after year. And clearly this is a level of precision that's far greater than can be achieved by even the most avid calorie counter. And so it's not surprising that maintaining this balance requires nearly every organ system in the body and is incredibly complex. So my lab studies the energy intake side of this equation. And in particular, we study communication between 2 organ systems, the GI tract and the central nervous system, in regulating appetite and driving behavioral and metabolic changes that promote body weight maintenance. So the GI tract is what first senses nutrients upon ingestion, and it communicates with the central nervous system in at least a couple of ways. So there is humoral communication from hormones released from the gut that communicate directly with circumventricular organs in the brain via the bloodstream. And then there are at least 2 neural feedback systems via spinal nerves and vagal afferent nerves that communicate from the proximal digestive tract directly to the brainstem, and then from the brainstem communicate to a large number of other brain regions, including the hypothalamus. And feeding centers in the hypothalamus then go on to drive appropriate behavioral responses, for example, meal termination at the point of satiation, and metabolic regulation, so altering glucose metabolism from the fasted into the fed state. And the specific neurons that I study in this regard are a small population of neurons at the base of the hypothalamus called Agrp neurons. These neurons are genetically defined by the expression of the neuropeptide Agrp. And in a really rich literature going back about 25 years that I won't get into in depth, we know that these neurons are absolutely critical for maintaining feeding in mammals. Specifically, if you ablate these mice, if you kill these mice in adult mice, mice will starve to death within about 5 days. So the way that we study Agrp neuron activity in mice as it pertains to gut-brain communication is via fiber photometry. So this is an in vivo bulk calcium imaging approach, wherein we express a fluorescent calcium indicator, in this case, GCAM6S, specifically in our neurons of interest, in this case, Agrp neurons, using a Cre recombinase system. And the way this works, without belaboring the method too much, is that GCAM6S fluoresces green, and that fluorescence increases as calcium rises in the cell and decreases as calcium goes down in the cell. And of course, calcium increasing in the neuron is a sign of neural activity. Calcium decrease means the neuron is less active. So by tracking green fluorescence in the neurons from second to second, we use that as a proxy for neural activity. And we do this using by connecting the mouse's head via fiber optic cable to a detection system and a processor, and can literally watch on a computer screen from minute to minute the activity of these neurons. And I developed a model during my postdoctoral fellowship wherein we can perform these recordings in awake behaving animals while we are infusing nutrients directly into their stomach. And this allows us to track Agrp neuron activity as a result of nutrient intake in the absence of the normal sensory components of feeding. So of course, normally when you eat, the sight of the food is an important component of it. The smell and the taste of the food are very important. And these external sensory factors have a big independent effect on Agrp neuron activity. And what we really wanted to study is what do the nutrients hitting the gut do to Agrp neuron activity? And so what I showed during my postdoc is that intragastric nutrients are sufficient to inhibit Agrp neurons, and they do so independent of macronutrient identity. So starting here on the left, you can see that when we infuse glucose in red, over the course of about 30 minutes, Agrp neuron activity declines, and it stays down for at least 30-45 minutes following infusion. And by contrast, water infusion, which of course has no caloric content, but if we infuse the same volume of water, it has no impact on the activity of these cells. If you infuse a fat emulsion, you see the same response. And if you infuse a peptide solution, you see, again, a very similar response. So the response is independent of macronutrient identity, but it is proportional to the amount of calories you infuse. So as I infuse the same volume of an increasing concentration of glucose, you see a more profound inhibition. Same with a lipid emulsion and a peptide emulsion. So we next wanted to begin to get at mechanism. What are the molecular components that are responsible for driving this inhibition? And is this inhibition that's being caused by all the different macronutrients we tested? Is it being driven by a common mechanism or distinct mechanisms depending on the macronutrients? And to cut to the chase, the mechanisms by which each macronutrient inhibit Agrp neurons appear to be macronutrient dependent. And we tested this using, or we demonstrated this using a pharmacologic approach. We had shown that the hormone cholecystokinin, which is of course released in response to fat-rich meals, is sufficient to inhibit Agrp neurons. And we next tried to block CCK receptor action and see whether we could block the response of Agrp neurons to nutrient infusion. And here's a model of how we did this experiment. We took a fasted animal, habituated it to a recording chamber, and then delivered either a CCK receptor antagonist or a vehicle, and subsequently infused either water or nutrient. And looking at fat here, you can see in red, similar to the prior slide I showed you, if you infuse a lipid emulsion, Agrp neurons become dramatically inhibited over the time course of minutes. Water, as you can see again, causes no change in activity. And in gray here, if you pre-block CCK receptors with an antagonist and then infuse a lipid emulsion into the stomach, you almost completely block the response of AGRP neurons to the nutrient. So CCK receptors are absolutely critical for the AGRP neuron response to fat. By contrast, doing the exact same experiment with glucose, we found no effect. So glucose in yellow causes the dramatic response of AGRP neurons. When we pre-block CCK receptors, you still see that exact same response. So how does glucose drive AGRP neuron inhibition? And that's been a major focus of my lab as we've been getting started up. So we started with a couple of really the most basic questions. One, there's this rich literature of sweet taste receptors, not just in the mouth, but lining the entire proximal GI tract, being important for food preference and other behaviors in mice. So we asked, is glucose activating the sweet taste receptors to inhibit AGRP neurons? And we know now that that's not the case, because while glucose in red here on the left causes the dramatic inhibition of AGRP neurons, the non-caloric sweetener sucralose causes no change in AGRP neuron activity, despite the fact that it acts on these sweet taste receptors. The second kind of low-hanging fruit hypothesis that we approached is it just blood glucose? Maybe we pump glucose into the stomach, it gets into the bloodstream, and there's also literature suggesting that at least some AGRP neurons are directly glucose responsive. But we found that this isn't the case either. So again, here in red, with glucose infusion into the gut, you see a sustained inhibition of AGRP neuron activity. But when I give the same amount of glucose as an IP injection, an intraperitoneal injection, bypassing the gut, but raising blood glucose to a comparable degree, you see instead of that nice sustained inhibition, a really transient inhibition of AGRP neurons that then returns to normal, despite the fact that these mice have comparable blood glucose levels throughout this time course. So from this, we concluded that there seems to be something about the gut that is important for driving this sustained AGRP neuron inhibition. From here, we went to kind of asking questions about, is it absorption, is it metabolism in the gut, and so forth. So, kind of taking it from the gut lumen on in, we first asked whether glucose absorption by enterocytes is required for AGRP neuron inhibition. And glucose is, of course, absorbed into the intestinal cells via the glucose sodium cotransporter SGLT1. And it turns out that this is absolutely required for the AGRP neuron inhibition by glucose. So similar to the prior CCK experiment I showed you, we pre-treat mice with either a vehicle or an SGLT1 antagonist followed by glucose infusion. And you can see here that vehicle pre-treated mice show this nice glucose-dependent inhibition, whereas the mice pre-treated with an antagonist show almost a flat line. So you need SGLT1 to inhibit AGRP neurons. Now the glucose is in the enterocyte. Does it have to be metabolized for AGRP neuron inhibition to occur? In the interest of time, the answer is no, it does not. We can use glucose analog, which is absorbed by SGLT1, but then is not glycolytically processed, called 3-O-methylglucose. And you can see that in preliminary experiments that 3-O-methylglucose inhibits AGRP neurons exactly the same as glucose does. So with this gut connection and absorption connection, our mind went immediately to incretins and insulin. Is incretin potentiated insulin release potentially driving the sustained inhibition of AGRP neuron activity? We have some exciting incretin related data that's a little bit too preliminary to share confidently at this point, but what we do know is that insulin inhibits AGRP neuron activity in vivo in a beautifully dose-dependent manner shown here. Of course, insulin treatment also causes hypoglycemia in a dose-dependent manner shown here. So we're in the process of starting to do some clamp experiments to show whether this AGRP neuron inhibition caused by dose-dependently by glucose is a bona fide effect of glucose versus of hypoglycemia or a counter-regulatory response. So as we work through that, just very briefly, we're also beginning to study how overnutrition and obesity affect this axis. We use the same model wherein we record from neurons during gastric infusion, this time in lean mice, in mice following diet-induced obesity, and in mice after weight loss. We show that diet-induced obesity attenuates AGRP neuron inhibition in a nutrient-selective manner. So we overnourish mice with with a high-fat diet, and their response to dietary fat decreases. So at baseline, they have this nice response to lipid, and that goes down after obesity, though their responses to glucose and peptide do not change. And interestingly, their response to lipid does not come back with weight loss. So over here on the right, you see the response in black at baseline, in red after obesity, and after 4 weeks of weight loss. There's no return to baseline of their response to dietary fat. And so we believe this is a novel potential circuit-based explanation for recidivism following weight loss. Even after you lose weight, your gut-brain axis no longer finds fat, which you've been overnourished with, to be satiating, and thus you must consume more of it to become satisfied. So things we're working on now, the incretin and insulin axis is probably the #1 thing we're working on, and how glucose mediates Agrp neuron inhibition in healthy mice. We are beginning to try to understand how carbohydrate overnutrition, and as opposed to the high-fat diet overnutrition that I just briefly showed you, affects neural dynamics and appetite. So if high-fat diet decreases response to fat, does a high-sugar diet decrease our response and satiation of sugar? And ultimately, of course, the goal is to understand whether we can intervene either nutritionally or pharmacologically to normalize dynamics, neural dynamics, appetite, and body weight across a spectrum of metabolic and energy homeostasis diseases. And thank you to my postdoc lab, to the endocrine division at Northwestern, and to the brave people who joined my startup lab. And I'm happy to take a couple questions if there's time.
All right. Thank you so much, Lisa. That was great. I don't see any questions yet, so I'm going to start by asking one. So one observation and then a follow-up question to that. Now, I noticed that your sort of peptide infusions didn't quite inhibit Agrp neurons quite as much as fat or carbohydrate. But what do you think might be linking peptide or protein to Agrp inhibition? Because that was the one thing you didn't show us.
Right. So peptides are a big black box. I'll start by addressing the fact that it looks like they don't inhibit Agrp neurons to quite the same degree. Depending on the exact peptide mixture that you're infusing, and this is all like bodybuilder, like flavorless type stuff. So we don't know exactly how the amino acid composition varies from lot to lot. And it's a little bit more or less depending on the lot. So I think that there's probably some amino acid or di or tripeptide specificity to what is inhibiting Agrp neurons. That said, how peptides inhibit Agrp neurons is a really huge black box. Ways that I've tried to approach it unsuccessfully thus far are to take an approach where I infuse either essential, non-essential, glucogenic, non-glucogenic mixtures of amino acids to see whether any one of those is sufficient to inhibit Agrp neurons. And there are one, we haven't found like a subset of pure amino acids that are sufficient. So maybe it's a peptide phenomenon. And two, as you break things down into the amino acids, you get into osmolarity issues. If you're just infusing a bunch of individual amino acids, the mice get kind of sick. So it's a very long way of saying we don't know. Yes, it does look like it has less of an effect, but that's really variable depending on what specific mixture we're using. So I think there's something to like an amino acid code that the brain is interpreting.
Okay, well, we're going to do one more question. Jonathan Flack, who's at the IBRI, has the question. Have you observed any heterogeneity in the response of Agrp neurons? Do they all respond to the same signals as one single population?
That is a fantastic question. So in terms of nutrients, we have not done single cell imaging. So we don't know if glucose inhibits a different subpopulation versus lipids versus peptides. What we do know from other work is that when you just feed a mouse, if you take a hungry mouse and give it chow, Agrp neurons become inhibited very, very rapidly, and it is a very homogeneous response. So if you give a hungry mouse chow, roughly 90 to 95% of the Agrp neurons just shut off right away. And then there's some debate within the field as to what the importance of those, 2 to 5 or maybe 10% of neurons that don't become inhibited are. That's not the focus of what we're working on, but they seem to respond fairly homogeneously.
All right. Thank you so much, Lisa. That was a great talk. And we're going to move on in the interest of time. So the last person that I'm going to introduce today is Dr. Daisy Sahu. Dr. Sahu is professor of medicine and vice chair for research at the Medical College of Wisconsin. She got her bachelor's at the University of Ottawa in Canada, and then she subsequently got her PhD at the University of Alberta. She pursued her postdoctoral work at Stony Brook, where she began her studies on the receptor for high-density lipoproteins. She's received continuous NIH funding to study how the structural features of the scavenger receptor influence HDL cholesterol clearance. And in 2017, she received the Special Recognition Award in Vascular Biology from the American Heart Association in recognition for her scientific contributions, as well as her service to the AHA. So Daisy, really looking forward to hearing about HDL and beta cell function.
Thank you so much, Raghu, and thank you to the organizing committee for inviting me to speak to you today about a new area of investigation that's trying to explore whether or not there really is a connection between oxidized HDL and beta cell function. I have nothing to disclose. So I think it comes as no surprise to many people in this audience that HDL cholesterol levels and LDL cholesterol levels are important determinants of cardiovascular risk. Specifically looking at the Framingham Heart Study data, I think it's very clear that very high levels of LDL cholesterol coupled with very low levels of HDL cholesterol are increased risks for cardiovascular disease. This increased risk for cardiovascular disease with low HDL was verified by a really interesting study that came out from this Danish study a couple of years ago that examined over 100,000 patients and looked at low HDL cholesterols and the correlation with cardiovascular risk. But what they also found was that very high HDL cholesterols also increased mortality in humans related with cardiovascular disease. And the magic number for men is anything greater than 73 mg per deciliter, and for women greater than 93 mg per deciliter. This falls in line very nicely with some of the HDL raising therapeutics that have been developed that have successfully raised HDL cholesterol levels, but unfortunately have had little to no cardiovascular benefit. And that's shown here by the status of many of these clinical trials that have just terminated because of no cardiovascular benefit. So this has really changed the way that we are thinking now about HDL cholesterol in the field and wondering, is it really HDL cholesterol levels that matter when we think about cardiovascular risk, or is it more importantly how well that HDL functions? Is HDL function a better predictor of disease risk? And when I talk about disease, it's not just cardiovascular disease, it's many other diseases that include diabetes, as you will see will be relevant for the talk later today. So one of the ways by which HDL can become dysfunctional is through its oxidative modification. And there are many papers in the literature that talk about the modification of HDL particles by myeloperoxidase or hypochlorous acid, copper, isolevuglandins. And the three that I will focus on today are reactive aldehydes such as 4-hydroxynonenal, malondialdehyde, and acrolein. These are all products of lipid peroxidation and all have been found at high levels in patients who have cardiovascular disease. Interestingly, patients with diabetes also have elevated levels of these very specific reactive aldehydes. So the premise for the studies that I'll talk about really started from some earlier work in my lab that was led by these three graduate students that studied the effects of reactive aldehyde modification of HDL and their potential impact on the cardioprotective effects in macrophages. So very briefly, what we did is we took HDL and modified it with these reactive aldehydes individually, so with either HME, MDA, or acrolein. And these three blots on the right demonstrate adduct formation by H&E, MDA, or acrolein through immunoblot analysis. On the left-hand side, I show you an immunoblot for ApoA1, which is the main protein component of HDL. And when it is modified by any of these reactive aldehydes, we see the expected laddering effects by showing these crosslinks on this immunoblot. So we are pretty confident we have been able to modify our HDL particles with reactive aldehydes and have also verified this by mass spec analysis. One of the first experiments we did was in macrophages to actually generate foam cells by incubating macrophages with oxidized LDL, which is known to trigger lipid accumulation, specifically cholesterol accumulation in macrophages, to trigger foam cell formation, which is the beginning of the atherosclerotic process. And when you incubate these macrophages for another 24 hours with oxidized LDL, you can see an increase in foam cell formation in these macrophages. What was really cool is when you incubate these macrophages with HDL, it's not surprising that the foam cell formation goes down because HDL's job is to take cholesterol out of macrophages and deliver it to the liver for excretion. So HDL here is doing its job. However, when HDL is modified by acrolein, you can see that the macrophages behave very similar like oxidized LDL incubated macrophages, and acrolein HDL actually, through other data I don't have time to show, promotes lipid accumulation in these macrophages. We were also able to demonstrate that one of the key components of foam cell formation is the ability to have these macrophages trapped, or in other words, prevent macrophage migration. So HDL's job really is to promote the migration of macrophages instead. And when we look at our modified HDL particles, unlike native HDL, they are unable to promote macrophage migration, again demonstrating another cardioprotective effect that's impaired in macrophages. And then finally, we looked at the ability of these modified forms of HDL to generate ROS, or reactive oxygen species, in macrophages. And just like what we see with oxidized LDL, we see that MDA HDL, but not the other forms of modified HDL, is able to promote ROS generation in macrophages. So these data kind of set the scientific premise for why we wanted to look at the role of modified HDL in perhaps impairing beta cell function and promoting diabetes. So that's what the next set of studies is going to talk about. So what exactly do we know about HDL in diabetes? What we do know is that dyslipidemia is a prominent feature of type 2 diabetes and is often reflected by very high levels of LDL cholesterol and low levels of HDL cholesterol. We also know that beta cells can become dysfunctional if they accumulate intracellular cholesterol, and mice that have this feature by specific knockout of certain proteins that inhibit cholesterol export, the mice have impaired glucose tolerance. HDL is also known to reverse LDL-induced apoptotic death and ER stress in isolated islets and transformed beta cell lines. And LDL is known to inhibit glucose-stimulated insulin secretion from human and mouse beta cells. And HDL has opposite effects, or it can inhibit some of the bad effects that LDL has on these cells. So I wanted to acknowledge at this point two of my lab staff, Sarah May, who is a postdoc, and Haley Powers, who is my MSTP graduate student who really drove this project. And they wanted to test the hypothesis that modification of HDL by reactive aldehydes would impair beta cell function. So we tested three specific questions. The first one was, can modified HDL promote lipid accumulation in beta cells, just like what we saw with macrophages earlier? So in these experiments, and actually all the experiments I'll talk about, we looked at INS-832 rat insulinoma cells. We pre-incubate these cells with tritiated cholesterol and monitor its movement out of cells into HDL particles. And to our surprise, we noticed that the acrolein HDL and MDA HDL, neither of them had any differences in their ability to mediate cholesterol efflux as compared to native HDL. This was kind of surprising, but also not surprising in the sense that ABCA1, which is a cholesterol transporter responsible for exporting that cholesterol out, its mRNA levels didn't really change in the presence of these modified forms of HDL. So then we said, okay, if efflux isn't changed, what about cholesterol import? So we looked at our favorite protein, which is SRB1. It's the HDL receptor that's primarily responsible for delivering cholesterol into cells. And we got excited because it looked like, at least at a protein level, SRB1 levels increased in the presence of modified forms of HDL, even though their mRNA levels didn't really show any difference in these cells. However, when we looked at the beta cells and incubated HDL, it's double radiolabeled, I should say that first. The I-125 monitors HDL binding, and the tritiated cholesterol ester monitors cholesterol ester uptake into cells. Again, we didn't see any differences in the ability of HDL or modified HDL to bind to cell surface receptors in the INS cells, nor was there any difference in the ability of these receptors to mediate cholesterol ester uptake. We have yet to still measure changes in cholesterol mass by GCMS. The next question we asked was whether modified HDL could promote ER stress in beta cells. So we started by looking at the splicing of XPP1, which is a marker that's in the unfolded protein response in response to ER stress. And what we see here is that when you incubate cells with thapsigargin, you are able to see the spliced form of XPP1, which suggests ER stress. And with increasing concentrations of HDL, we're able to prevent that splicing and hence prevent ER stress. And again, we see the same pattern where when we modify HDL with acrolein, we see the same pattern where even acrolein HDL behaves just like native HDL and also seems to prevent ER stress. We then looked at another marker, which is ATF4, in the presence of cells that were incubated with thapsigargin. We were happy to see that the ER stressor thapsigargin is able to promote ER stress as shown by high levels of ATF4. However, when we incubate with the cells with higher levels of increasing levels of HDL, we noticed that ER stress is prevented as shown by decreasing levels of ATF4. And again, the same pattern is shown with the modified forms of HDL, and that's quantified for you here on the right. We see similar patterns with tunicamycin, which is a glycosylation inhibitor that's known to induce ER stress. I want you to focus your attention on this line here of bands, which is better quantified on the right-hand side, but same patterns. Tunicamycin can trigger ER stress that is prevented by HDL and interestingly also by the modified forms of HDL. We have yet to measure BIP, CHOP, and phospho-EIF alpha, EIF2 alpha, and we also are thinking about looking at other forms of ER stress that can be induced by fatty acids such as palmitate or high levels of glucose. The last question that we addressed was finally whether modified HDL could reduce glucose-stimulated insulin secretion from beta cells. And so again, same pattern, no differences when we incubate these cells in low or high levels of glucose. The modified forms of HDL trigger similar levels of insulin secretion as native HDL. So what have we learned so far? We were obviously a little bit disappointed that the hypotheses that presented were not validated by the data we've been able to collect so far. Specifically, we showed that modified HDL behaves just like native HDL. And to show that, we demonstrated that by showing that when you incubate these INS cells with modified HDL, we cannot promote lipid accumulation, we do not promote ER stress, and we do not reduce glucose-stimulated insulin secretion. But what we also have learned is that there's a lot of controversy out there in the literature, and as we move forward, there are a lot of things that we need to think about. In the literature, a lot of these experiments were performed in Min6 cells, and specifically for insulin secretion, from what I have learned from my colleagues, these are not necessarily the best cells to use to study insulin secretion. So cell type could certainly make a difference. You may have also noticed that the levels of HDL that we were using in our experiments were abnormally high, and we were trying to replicate what we saw in the literature with just native HDL, but is that really physiologically relevant? So the literature that's out there, are they looking at HDL levels that really make sense when we think about human physiology? We also have to consider that HDL has a very complicated proteome with over 100 different proteins around its cell surface, and it has 100 different lipids and microRNAs that can also complicate mechanism and data interpretation. And finally, we're looking at HDL modified by reactive aldehydes on an individual basis. But of course, in the body, HDL is likely modified by numerous types of modifiers at the same time. So the type of modification present on the HDL particle may also be a significant impact, may also have a significant impact on the cellular function. So a lot of things to think about as we move forward with these studies. And at this point, I would like to thank you for your attention and acknowledge the members of my lab, particularly Sarah and Haley on the right-hand side here, who drove these studies. I also want to thank John Corbett's lab, specifically Polly Hansen, who taught us how to do the glucose-stimulated insulin secretion assays, and Jennifer Stansel for providing us with a lot of antibodies and reagents to help with these studies. And of course, none of these pilot studies would have been possible without the generous support of a DRTC pilot grant from the University of Chicago. So thank you again for your attention, and I'll be happy to take any questions.
Thanks so much, Daisy. That was great. So maybe a couple of questions, and then we need to move on. But I'm gonna start since I'm a moderator here. So it almost seems like, you know, either HDL or the modified HDLs are actually protective, right? Because you see reductions in ER stress, and so I guess my question would be, just is HDL, effectively serving as a sort of, if you will, a scavenger for some of these lipid peroxides, and could that be protective in the beta cell?
That's a really great question, and absolutely, HDL has been shown to play that role. It is an antioxidant, right? It also has peroxidase around its surface, and it can certainly sop up oxidized lipids. So that's absolutely something that we should be considering as we're doing these experiments. Thank you for bringing up that point.
Yeah. Okay. Let's see here. Let's see. There's one question from Matthew Brady. Random question. He says, if there is a copper modified form of HDL, is there a possibility for zinc modified HDL in beta cells?
I have not actually looked that up. I have never seen any lipoprotein modified by zinc in vitro studies. I also don't know if there has been zinc modified lipoproteins identified in patients. That's something I will certainly look up after this, Matthew. Thank you for that question.
All right, well, we got to move on. I'm going to turn this over to Albert. Take it away.
All right. Thank you, Raghu, for moderating those excellent talks. I'm happy to introduce our next speaker, who is Pamela Martin-Nemeth. Dr. Martin-Nemeth is associate professor in the Department of Biobehavioral Nursing Science, College of Nursing, University of Illinois, Chicago. Her research focuses on improving self-management behavior and quality of life in persons with type 1 diabetes. She's currently conducting 2 studies funded by NIDDK, one examining the role of cognitive behavioral therapy in reducing fear of hypoglycemia in young adults, and a second is testing a sleep intervention to improve glycemic control in persons with type 1 diabetes. Dr. Martin-Nemeth, please take it away.
Great, thank you. Thank you for that nice introduction. Good morning, everybody. What I'm going to be presenting on is a pilot study that was funded through the CCDTR that we are very thankful to have received. And these are my financial disclosures. So as you're all well aware, achievement of near normal glucose levels is associated with reduced micro and macrovascular complications. But despite improvements in treatment regimens and technology, less than 20% of adults with type 1 diabetes achieve glycemic targets. Sleep insufficiency and sleep variability may adversely affect glucose control and are potentially modifiable. And these are 2 areas that we decided to focus on, because in some previous focus group studies we had done examining contemporary diabetes challenges, sleep challenges emerged as one of the most significant problems that working adults with type 1 diabetes faced. And these were some of the comments that we received. Sleep is probably the most dangerous time. The majority of my low occurrences were while sleeping. A second said, if I get a full night's sleep above 200, it's not a very good sleep. I generally wake up very groggy. It's usually the worst nights of sleep, so that happens a little bit more regularly. And thirdly, it's very complicated. I don't think I've gotten a good night's sleep in probably about 10 years. It's so many different things colliding. So because of these challenges, we developed an intervention which was actually based on a an intervention focused on people with hypertension that Kelly Barron and Jenna Duffy had developed called Sleep Bunny. So we modified this to be more focused with people with type 1. And our study aims were these: to determine the effect of an 8-week sleep intervention, which we called Sleepopt, compared to an attention control group on sleep duration and variability. Variability being the pattern and regularity of the sleep schedule. Secondly, to look at glycemic parameters, specifically glycemic control, glycemic variability, and time in range. And then also to look at some patient-reported outcomes, specifically diabetes, distress, fatigue, and mood. This was a randomized controlled pilot study with working adults 18 to 65 years of age who had type 1 diabetes for a minimum of 1 year, with self-reported sleep duration less than 6.5 hours or sleep variability greater than 1.5 hours on average during the work week. They were excluded if they had sleep apnea, insomnia, or shift work, and were randomized to Sleepopt or our attention control group at a ratio of 3 to 2, because this was a small pilot and we wanted to assure that we had more people in the Sleepopt group. So the Sleepopt intervention was an 8-week remotely delivered intervention where they had 3 components. They received weekly digital content, they received weekly telephone coaching, and that telephone coaching was 5 to 10 minutes in length, but it was focused on their specific sleep issue and targeted on setting goals. They also used a Fitbit in order to track their sleep and also to assist with goal setting. And what you see on the right was a picture of one of the digital lessons that went to their inbox. This one was the first one that they received on introductions and basics of sleep. You may have noticed there are a lot of pictures of puppies and babies and animals throughout these slides. These were pictures that were incorporated into these digital lessons because the participants felt that they resonated well with the pictures. Those in the Healthy Living Attention Control group also received 8 digital lessons, but they didn't have anything to do with sleep. They were topics such as this: healthy cooking skills. They also received a weekly phone call, but it had no coaching related to it. It was specifically, did you get the lesson, answering any questions that they might have had about it. And they did not use a Fitbit. So our conceptual framework was that of supportive accountability. So that this connection with the coach created the human bond that they were accountable to for setting goals and performing and meeting expectations. And that this coach was seen as a legitimate person with expertise who was trustworthy and benevolent. And we thought that that would help to improve adherence with the Sleepopt program. What you see here is our study schema. We collected data at baseline, week 0, at the end of the intervention at week 8, and then at follow-up 4 weeks later at week 12 to assess sustainability. We collected objective sleep data using Philips actigraphy over 7 days. Concurrently, we measured glucose variability with CGM with the Abbott Libre Freestyle. We drew a blood sample for A1C, and then participants completed questionnaires on diabetes, distress, fatigue, and mood via REDCap. So we did have some unexpected findings. What you see here are 2 actograms from 2 participants, and these are over 5 days, and it's a 24-hour period. The aqua bar indicates the sleep period, and you'll notice in the first actogram on the left that those aqua bars are falling pretty regularly. A person's going to bed at about 11 p.m. every night and getting up around 6 a.m. every night. The person on the left has a much more variable sleep schedule, so you can see that there's a lot of variability in where those bars are placed. We were expecting that people would really suffer more from short sleep duration. But what we found instead was most of these participants had adequate sleep duration. The problem was sleep variability. So that's what we focused on in the Sleepopt intervention, is their specific issue which more than often was sleep variability. And what I'm showing you here are the results from that study. These are the mean differences from baseline to post-program, with the Sleepopt group in the middle column and the healthy living control group on the right. Remember that we randomized 3 to 2, so we have more people in the Sleepopt group. And these are the mean change scores from beginning to end. Sleep duration had a negligible improvement in the Sleepopt group, whereas almost a half hour in the healthy living control group. But remember, we didn't have sleep duration. Short sleep is a problem to begin with. So we wouldn't have expected that to improve. It's interesting that the healthy living group started sleeping longer while they were in the control group. Talk about that a little bit later. We measured sleep variability as mid-sleep clock time standard deviation. So that's the time on the clock where their mid-sleep would be. And if you have a fairly regular schedule, we would see a fairly small standard deviation there. And in our Sleepopt group, we did see a reduction by 0.43 of an hour. So that's nearly a half of an hour change, where we saw no change in the healthy living control group. A1C decreased in both groups, more so in the healthy living control group, but I have to say that our Sleepopt group had A1Cs of 5.4 to 7.4% to start, so they didn't have much room to go. Glycemic variability, on the other hand, was reduced by about 3% in the Sleepopt group, whereas it increased in the healthy living control group. Time in range increased by 11% in the Sleepopt group and less so in the healthy living group. And the other two components that we saw a big change in were fatigue and mood. And the Sleepopt group had a reduction in fatigue with the PROMIS scale of 8.7 points, whereas the healthy living control group had a rise. And then the mood also improved in the Sleepopt group, whereas it worsened in the healthy living group. So our results really showed that first, we think we had a very highly reactive control group. They started sleeping longer. One of them even admitted to me that they were reviewing podcasts on sleep. But they wouldn't have known to improve their sleep variability. And we did see sleep variability improving in the Sleepopt group. A1C decreased in both groups, but knowing that the Sleepopt group had very low A1C levels to begin with, glycemic variability was reduced and improved in the Sleepopt group by 3%, and time in range increased in the Sleepopt group. Not to mention, and we were somewhat surprised by the extent of the improvement in the subjective scores on fatigue and mood, which improved in the Sleepopt group and actually worsened in the control group. So in conclusion, the 8-week pilot study demonstrated proof of concept that those with high sleep variability may benefit from a sleep optimization intervention. And we planned a larger RCT, which was funded last July. So through the NIH, NIDDK, and we're very excited about that. We're now entering our second year. We learned a lot from the pilot study that we've improved upon in our larger study. I want to acknowledge my collaborators, which are Sarah Richard Cal, Jennifer Duffy, Lori Quinn, Kelly Barron, and Elena Steffen. And of course, the Chicago Center for Diabetes Translation Research, because without the pilot funding for this study, we wouldn't have completed that, nor would we have the RO1 that we're conducting now, and other acknowledgements as well. So thank you.
Thank you, Pamela. That was great, and congratulations on the success of the pilot and the ongoing RO1. So I have a question actually that's shared by Amisha, which is, what was the role of continuous glucose monitoring in your study or in the ongoing trial? And actually, I have a broader question, which is your intervention, Sleepopt, is primarily a behavioral intervention. And I guess the question is, how does that interact with something like a technological intervention like CGM?
So we were actually hypothesizing that improving sleep would improve insulin sensitivity, and that we might see a reduction in high glucose variation. That was one piece of the rationale for continuous glucose monitoring.
But I guess the question I'm asking is, could CGM be actually an alternative intervention because of its alerts related to hypoglycemia, could CGM by itself have a beneficial effect on sleep?
In this study.
Or
Yes.
in type 1 diabetes in general?
I mean, sure, absolutely. Now, in this study, we used it as just a recorder. So
Yes.
the Abbott Freestyle, they could not see. We use the professional version where we turn it on and they can't see what they can't do flash monitoring or anything like that. But you're absolutely right. And if you are able to monitor your glucose, minute to minute, that might make an improvement too. Actually, we have another study that we're doing just that, but both groups have CGM that they can see in real time to help to control for that. So I don't know if that helps answer your question. In terms of can you ask me the behavioral question again?
I think you answered it. Your
Okay.
experiment is essentially a purified study of a behavioral sleep intervention in type 1 diabetes. It's not you may be looking at the combination of behavioral and device in some other, in a future study, but not in this one. Great. What were the participant responses to the sleep? What were the sort of qualitative responses from subjects?
Yeah, so we had some very positive, people reacted very positively to it. We actually utilized some of our participants in providing feedback in our future digital lessons that we're using now. But yeah, we had an overwhelming interest in the topic area because sleep was such an issue. And they really benefited from the sleep coach. I mean, we couldn't they couldn't say enough positive things about the sleep coach for that very brief 5 to 10 minute interaction that they had. I think the question is what'll be the secret sauce as they go forward without a coach to maintain that. We're hoping that learning to use a Fitbit or some type of technology like that to set your goals and get that feedback and monitoring might be able to be transitioned to be able to do that more independently.
Great. Thank you very much, Pamela. We're
Thank you.
unfortunately going to have to move on. And the next speaker is Dr. Amisha Walia. And Dr. Amisha Walia is a clinical trial expert, health services researcher specializing in creating chronic care solutions for those with diabetes on high-risk medications. She has collaborated across disciplines, including engineering, product design, and utilized novel methods such as user-centered design, pragmatic trial methodologies to help frontline clinicians innovate new care solutions to improve diabetes care. Dr. Walia, we're happy to have you.
Hi, how are you? Sorry about that. So give me one second. Well, thank you so much for having me today. Thank you for the warm introduction. So I'm going to be talking about some really exciting work I've been doing with cross collaborations in the McCormick School of Engineering within the Division of Endocrinology, as well as a new Center of Human-Computer Interaction. So I do not have any disclosures related to this exact topic. So when we talk about diabetes education and survival skills, it's actually what we call a wicked problem. What is a wicked problem? It comes from social policy planning and anthropology, where wicked problems are problems that are difficult to solve because of incomplete and contradictory and changing requirements. You have multiple stakeholders with different, often selfish perspectives and real-world constraints which prevent multiple and risk-free attempts at solving the problem. Why is diabetes self-care or diabetes survival skills an actual wicked problem? Well, diabetes survival skills are actually essential for anyone with diabetes. It's actually highly complex, and this is something that I actually began to learn myself recently, that it actually encompasses both conceptual knowledge as well as procedural steps. And as someone who has seen a lot of patients with diabetes, I will definitely say each individual person has a different level of understanding of various components of what would be conceptual components of knowledge and procedural components of knowledge. Very, very low % of patients actually get formal diabetes education. So whenever I quote this, people always contact me and say, is that really true? But in large data sets, including CMS data as well as others, only 2.5 to 7% of patients actually get diabetes education. And generally this occurs during transitions of care and both medical and physical transitions, as well as this is a very high risk safety issue. And we haven't moved the needle on this over so many years. And so how do we develop effective solutions to wicked problems? And there's actually an entire anthropologic literature on this, which I will not go into, but I would say that we need to break down barriers within our own scientific worlds to do this. And this can definitely be shown by, if any of you guys remember this type of phone. I actually do remember this type of phone when I was young and played with it when I was my daughter's age. But think about the revolution that has happened with the iPhone as an example. So the iPhone and examples like that, really in the private sector, user-centered design has been at the forefront of technological change and adaptation into behavior. This is a schematic that many of you will see. The basics of user-centered design is actually focus, understand, define, conceive, build, and test. And then you identify the needs, you specify requirements, you produce design solutions, and you satisfy the system. So it's actually very simplistic in its nature. We did a very large risk assessment, so I'm just providing now some preliminary data about why we picked this topic, looking at the high-risk time of inpatient to outpatient transitions of care. And what we found was the number one internal failure was always delivery of diabetes survival skills and self-care, which is why we actually picked this topic. Over the last several years, we have interviewed over 100 users, which include providers, patients, caregivers, lay people, administrators, infection control engineers, and done over 70 learning collaborative design sessions to understand what the actual needs are. And I will not belabor our work, but you can see different prototypes. And just prior to COVID, we were about to start a clinical trial looking at our current toolkit, which is a software system with a hardware teaching toolkit, which provides simulation materials for patients. But when we started doing preliminary testing in COVID remotely, what we realized was we couldn't move forward in the peri and post-COVID era. And actually, having reviewed with my team some of the live Zoom videos of our participants, people are struggling at home in ways that I don't think we've fully understood. And so that is when we reached out to the Center for Human Computer Interaction Design and really wanted to utilize learning science methods to really understand what is the interaction of education and learning within different interfaces of delivery of education, or specifically procedural steps as well, such as injecting insulin. We utilize two different methods, which is needs mapping and then also a cognitive task analysis. In terms of the needs mapping, I will just generally highlight the major findings. We actually went back to some of our pre-COVID interviews with top users, patients, caregivers, and lay people. And we specifically then mapped to key learning principles, having our learning scientist colleagues actually go through the qualitative coding and try to map to key learning science principles. These were the original results prior to doing the learning sciences needs mapping. And if anyone has, taught a patient, we know, there's challenges in understanding self-care, there's challenges administrating self-care at home. I think one of the things that perhaps we underappreciate is the challenges in preparing items and understanding how these items lay into what's called procedural conceptual knowledge. So challenges in administering self-care at home. Here's a representative quote. For me, it was the dose going from what her blood sugar is to what I need to give, the correction. If I overdo it, we're really going to have more problems, which all of us are very familiar with hearing patients say that. And caregivers. And so I'm not going to belabor all the results, but the key result that mapped to several of our themes was something called spiral learning. And when I was talking to our learning scientist colleague about this, I was asking him to explain it to me in terms of now how we're going to do this in the design. And so he asked me, have I seen the show Cobra Kai? And I answered, I think I'm of the Karate Kid age. But what that means is that the real world learning example is martial arts training. So example, a white belt will learn about blocking just as a black belt will, but the conceptual knowledge and the procedural knowledge about the way to use blocking grows as you go through the belts. This can be very applicable, let's say, with insulin and food. So giving insulin for certain times with food, etc. And so moving on in terms from our needs mapping, then we moved on to doing something called a cognitive task analysis. So what is a cognitive task analysis? It describes the physical tasks and cognitive plans required for a user to accomplish their goal. Applied task analysis has been developed by systems engineers to elicit and represent performance. This is where you take experts and novices and you catalog, code, and map knowledge. So why can't we just have experts tell us what the knowledge they have? And so this is really regarding the expert blind spot. So think about all of you who've taught your child how to drive. So it can be very disconcerting you sitting them with the car and it seems almost overwhelming. But think about how each of us perhaps drive to work every day now without any forethought. And the same with, let's say, doing surgery. So how do we overcome the expert blind spot? It is cognitive task analysis, which learning scientists use. And it essentially, as we said before, you elicit knowledge through think aloud method. You do data analysis, which includes video analysis, and then a knowledge representation, which is represented through a hierarchical task analysis. And I will show you sort of what this looks like. User-centered learning design. So how does this fit into actually adaptation of our toolkit? So really the first part is focus, understanding, and defining. So you utilize the cognitive task analysis to understand gaps and differences in self-care knowledge and skills between novices, experts, and patients and caregivers. You use video interviews and then video analysis for the first several steps. And then you conceive, build, and test. So we undergo expert review of the changes in the design, and then you reiterate, do video analysis, re-review, and continue user testing. So an example of data collection, you have the expert talking out loud. You use process equipment and research questions to help expert describe knowledge. And then you conduct the same process with novices. In this case, we're really focusing on patients new to diagnose diabetes in the first week of self-care. We've completed several interviews to date, including endocrinology fellows, expert patients, attending endocrinologist, expert patients, as well as 3 newly diagnosed patients with diabetes. A general overview, this is what data collection looks like. Knowledge elicited, you utilize qualitative codes and then knowledge representation to then make a hierarchical task analysis of diabetes self-care. So this is what the HTA looks like in terms of expert knowledge. And then this is what a novice HTA looks like, where red squares represent steps patients do not complete or knowledge that they do not have that lead to errors. And zooming in on this, here's an example. Let's say patient doesn't take a second measurement after they have a low glucose and they have a high risk of recurring hypoglycemia, which really can be a clear conceptual knowledge deficit. So what are our future steps in wrapping up? So we're in the middle of creating knowledge representation, including a complete list of common critical errors novices make. You use that knowledge representation along with needs assessment to inform design. The development of more sophisticated technological interventions are needed. I want to reiterate here that this idea that you can, sort of put up diabetes education materials to patients and expect that they will understand actually these very complex educational needs is not possible. Having actually seen some of these videos at home, and each person, very interestingly, has different procedural or conceptual deficits. And then really this work will overlay what will be, what we believe to be the future, which is artificial intelligence to support telemedicine and build in intelligence agents to actually help patients develop and go through those stages to be an eventual black belt in diabetes. So here are my references, and I would like to acknowledge the CCDTR pilot funding as well as original funding back several years ago, as well as my colleagues in human-computer interaction in the School of Education and Social Policy.
Thank you, Amisha. That was, you really, I was thinking about how your talk was really about pushing diabetes education into the 21st century. So I just had, there are no questions in the Q&A, so I will just ask a question, just a thought experiment. I was thinking about your your methods in terms of hierarchical task analysis and so on. How does culture play a role, or the cultural background of the patient, or social determinants of health, I guess, relate to this human-centered design that you're taking on? Is there going to be more than one approach to finding solutions for for advancing education for a subject or moving them to the black belt stage?
Thank you, Albert. That is actually right on point. So when you look at the literature, there is in user-centered design and implementation science, there is a huge lack of data around how we reach the people who actually really need it. We don't design things for those users. Part of it, and this is something we struggle with, and I would love anyone reach out to me, there's my email, where besides actually in-depth qualitative analysis, which takes a lot of time and resources. A lot of people use the SUS, which is a system usability survey, which we've actually used, which I personally think is rudimentary in its understanding for older adults as well as underrepresented minorities. And so this is something we are tackling. Actually, interesting, there's been a lot of work done in this area at DePaul, interestingly enough. And there are some burgeoning, really talented young investigators who, with the COVID-19 era, are knocking on the door and saying, this is not enough. I will say that, as we know, recruitment and then reaching them takes an inordinate amount of time and energy. And actually, I think it's just, double the coordinator time. So I think we need to budget for that and really understand and go back to our funders and say, like, this is actually the time it takes to do this type of work.
Thank you very much. There is a question in the chat from Fran Kogan. Amisha, I hope that you can answer electronically, because we have to move on to the next speaker. Thank you very much.
Thank you.
So our next speaker is Dr. Cynthia Fritchie, who is Associate Professor at University of Illinois, Chicago. the overall goal for research is to develop real-world physical activity interventions in aging urban adults with or at risk for cardiometabolic diseases to maximize metabolic health, enhance quality of life, and accentuate the risks for early disability associated with being sedentary. The major focus of her work has explored the relationship between physical function, physical activity, and symptom experience among obese sedentary adults with type 2 diabetes. Dr. Frici, please take it away.
Okay, and I'm hoping, is my screen showing up?
It is.
Great, okay, I'm working off of two screens here. So thank you, and especially many thanks to the CCDTR at the University of Chicago, who kindly funded this pilot project. And one of the things I want to especially thank Amisha, the speaker right before me, because she really laid some foundational work. I have no relevant financial relationships, and might I add, unfortunately. So this is probably much repetition. The main thing here, though, is that on top of this lack of diabetes education, which I've seen in all of the patients I've worked with, we are also seeing that, especially in lower socioeconomic static adults, they have a much higher energy need. Everything is a little more difficult. They're spending more time both in caregiving, in managing their life situation. And we've talked a little bit about social determinants of health. And especially for women, self-care becomes very low on the totem pole. So what we found is that people have either had a single episode of diabetes education, usually when they're first diagnosed, and they've forgotten most of it. They do not monitor their blood glucose levels. They'll come in and they'll say, oh yeah, I do it once a day, and they really don't. Many of them have not monitored their glucose. So what I and my team were really curious about, and from prior studies, people really loved to know what their numbers were. They loved to see what was happening in their body. And so based somewhat in self-regulation theory and some other behavioral theory, we decided to use self-regulation theory to be able to help these women really sort of internalize that diabetes education and help them, eventually to change behavior, although this is sort of the first part of that larger study. So we gave them an activity tracker. We gave them a Fitbit wrist actigraphy monitor. We gave them a freestyle flash glucose monitor, which they could see. And this fostered self-monitoring and assessment of their numbers. We started with goal setting. So we set very simple goals. How many steps a day? Much fewer blood glucose goals. One woman set a sleep goal because we could get sleep data on her Fitbit. And so then they would watch their data. They would be able to see that, whether or not they were making their goals. And so they go through these periods of mental contrasting. Oh, my Fitbit says I need to get another 100 steps this hour. So as one woman said, I put my keys around my neck and I just walked up and down my hallway. We then went through goal review, goal revision when we met with the women. And so they would try to alter the methods by which they were going to achieve their goals. And we had given them little cue cards with their personal medication list, what their goals were. We also reminded them of what target glucose numbers should be, because many of them could not name an appropriate glucose number. They really had no clue. Over time, we're hoping this builds autonomous motivation. The whole process was started with small group education. We wanted to foster that social part of the education. We let the women drive the education. We had a piece on nutrition. We also had a piece on exercise where we taught them to do very basic sitting exercises, walking, what a brisk walk felt like, and that was very different for each of them. So we had an exercise physiologist whom they adored come in and do very brief, what can you do on a mat, sitting in a chair around your house. You know, how can you do push-ups against a wall sort of thing. So the aim was to determine the feasibility and acceptability of this ecological momentary intervention using the CGM activity tracking and these cue cards with their behavioral choices, and also their, you know, to see if changes in behavior might be driven by those glucose levels. We did not have a control group. We included only Black women who were aged 40 or over, and they had to have had type 2 diabetes greater than 1 year to sort of overcome that initial fear, unknowing about the disease. We did not include any women who used insulin. We really wanted to keep this to non-insulin using women. And one of the things that, you know, over and over again, there are white papers, there's much controversy about the use of CGM in people who are not on insulin. And I understand that. But I wanted to look at what about the behavioral implications of this. So in week 1, we had groups of 3 to 5 women. 5 may have been too many. We gave them sort of group diabetes education, which they directed based on their needs. We had some very interesting comments about food. That was their biggest area where they did not feel confident in any of their knowledge. They really, even though they may have met with a dietitian, food is usually, and this is also supported in the literature, the thing that's most confusing to people with diabetes. We helped them develop personalized exercise plans, and personal goals. And then we set them up with their activity tracker. They came back, we looked at the goal review, we went through problem solving. Again, we talked about their step counts, and then we set them up with a CGM because we felt that setting them up with a Fitbit, many did not have smartphones, had never used this technology before. So we decided to give them some time just to live with the Fitbit before we added on the flash glucose monitor. We saw them 2 weeks later for a sensor change, and then they came back 2 weeks later for another sensor change. We did activity track. We downloaded all their information. We did the final assessments, and we did a guided interview with questions about their experiences in the study. And this is just a picture of what the cue cards looked like. We'll just briefly, some of the semi-structured interview questions, you know, asking about their experiences, and then we asked about their experiences with each of the separate devices, about the education piece, what problems did they have, did it interfere with their regular day-to-day life? Because the whole idea was to decrease the workload. And so a lot of the reason people don't monitor their blood sugars is they felt they had to go someplace special, they had to pull it out, they had to give up time from their job. And we ended up, we had to cut the study in half, unfortunately, because of COVID. I had to close the lab. These were elderly. Most women had multi-comorbid conditions. It was not safe, even after we thought it might be okay to start up the study again. We ended up with 12 in the study. However, only 8 completed the intervention, all of the parts. So the average age was 69. We saw that they had very well-controlled hemoglobin A1Cs, and I think that was mentioned earlier today. So they didn't have a lot of way to go on A1C. We looked at, you know, on the average, about 18 years of having had diabetes. They very seldom monitored capillary blood glucoses. They all had hypertension, and their diabetes knowledge was fairly low. And this is person by person. But one of the things I want to call your attention to is that several of our women did not have cell phones. One had a cell phone she didn't know was a smartphone. So we really tried to structure this so that they would not need a smartphone. What we found in the people, unfortunately, we only were able to accumulate all of the survey data on 5 participants before we closed. But, you know, just even for these 5 people, we did find that there was a decrease in diabetes distress and a little bit of decrease in their perceptions of neighborhood problems. Others trended in the correct direction, so we're very hopeful. Okay, most importantly is what we got from our qualitative interviews. And one of the women, I loved her, you know, quote so much that this is the title of a paper that is under review currently. Something tells me I can't do that no more. And this was a woman who, after using her flash glucose monitor, had gone to McDonald's and she couldn't find anything healthy to eat at McDonald's. So she decided to have orange juice, which she thought was the healthiest thing. And the next morning her blood sugar was very high and she said, oh, something tells me I can't do that no more. So what we saw is this experiential learning. It was really exciting to see. The themes that came out of the interviews were consistent with self-regulation behaviors. They were experiencing the diabetes knowledge that may not have been thoroughly cemented. You know, you get one diabetes education class and it's via Condios. And so they were able to experience, to be able to see changes in their numbers, and they got excited by looking at their step counts every day. Many times there was evidence of mental contrasting. It's like, oh, that's too high. I'd better go do something else. So I stopped having a sandwich at night. I am now just having a lighter snack or some tea. So we found that they loved the education sessions. Diet was the biggest source of confusion. They really enjoyed being able to track their steps because most of them have never had access to these devices. They wanted more sensors after the study ended. They wanted to continue. They really enjoyed seeing the changes. They'd get excited when their numbers came down, or when they were able to figure out why that glucose number from a simple swipe, why that number was high. They were able to say, it's high because I did this, and now I know I'm not going to do that anymore. So despite not having had a large amount of diabetes education, they were actually learning on the go. They hated finger sticks. They hated finger sticks. They loved not having to stick their fingers. So we've applied for one of the small NIDDK R01s, and that's going back for resubmission in October. And we're hoping to be able to see a little bit more deeper. We're going to use a control group and have a better idea of some of the long-term, you know, the real effects from this process. And again, I thank my co-investigators and all of my lab team, and of course funding from the CCDTR. So I will leave it at that. Thank you.
Thank you, Cynthia. Let's see if we have a. And we probably have time for just one question or two from myself. I don't know if you plan to do this, Cynthia, but you actually unintentionally did a geriatric diabetes study because your subjects are actually quite old, and not surprisingly, as people get older, you know, one of the tricks in quality improvement is enroll as many older people as possible into your population. You'll have better glucose control. So just something to think about as you resubmit, that you could take a geriatric perspective. But you brought up this really important question about the digital divide, and I think your study shows that people, when introduced to the technology, can use it. But what are your thoughts about creating ways to scale this up and reach more people, given the digital divide you encountered, people not knowing they had a smartphone?
You know, the people who did not have smartphones didn't need them. We found that just for them being able to look at the very simple, we use the simplest Fitbit, you know, they could look at their steps. I know they're not accurate as a regular device. In the larger study, we are going to have a run-in period using research grade devices. But they were able to see just by looking at the watch, they can figure it out. They were able to see their steps. They were able to see how many flights of steps they've climbed and how many, how good their sleep was. And with the flash glucose monitor, the cost is actually, I don't foresee this as being a tool that they would use consistently every single day of the year. I'm thinking of this as something that they could check in with 3-4 times a year, something that either the clinicians could help them with. The cost of the sensors is not high. A couple of them mentioned they were going to ask for another sensor because they got to keep the CGM for a Christmas present. They were able to use them, and the flash system is not as expensive, certainly, as the Dexcom or the Medtronic. So it's potentially doable. Again, I don't think it would be something, that they would use every single day like somebody with type 1 diabetes would, or somebody on insulin.
Thank you. So that's very helpful. So the devices may be less expensive than we think, and maybe less frequent use is the way to save money on, in their deployment.
And a lot of the teachings they did on their own. So, I mean, they learned with
That's awesome.
us telling them every minute.
That's important. Cynthia, thank you so much. We're going to have to move on to our next speaker. Appreciate it, and congratulations. Good luck with the R01 submission.
Oh, thanks.
Our next speaker is Dr. Megan Heising-Sheets. She's assistant professor of medicine at University of Chicago. She's a geriatrician, epidemiologist whose research is focused on understanding how objectively measured activity and some sedentary behavior patterns, resting metabolic rate, and body composition relate to frailty progression and frailty-related outcomes. She's a co-investigator of the National Social Life, Health, and Aging Project, which is a homegrown, nationally representative cohort study at University of Chicago. And she is also the recent recipient of the 2021 Arti Huria Memorial Award, which is essentially an award for the country's top geriatrics young investigator. Megan.
Thank you, Albert. That was a very, very, very nice introduction, probably overstated. I'm really, really excited to be here. Again, my name is Megan Heising. I'm a geriatrician and clinician investigator at the University of Chicago. And today I'm thrilled to be able to talk to you about our program that we call Engage. It is a technology-based tool that leverages an Alexa device that targets older adult and care partner dyads to socially motivate long-term exercise participation, specifically among older adults in their home. This work is largely grant funded, but I will just mention that both the University of Chicago and NORC, the two kind of home institutions of the team, do own some intellectual property on the customized portions of this product. I will say, though, that this has been a financial sink and not a gain for all involved. So I'd like to start with the motivation for this program. This is an example of a patient that I see in the Successful Aging and Frailty Evaluation Clinic, which is a consult model that we started almost a decade ago to help support the care and caregivers of older adults who have multimorbidity or frailty. This is an example patient of mine. He has diabetes and multimorbidity. He's got early Lewy body disease. And over the last few years, he's been getting increasingly frail, which has essentially left him functionally and cognitively homebound. He requires his wife to leave the house, and he's become progressively socially isolated as a result of that. My role as the provider is to try to combat that functional decline cycle, or at least delay it, and prolong that independent lifespan. So I quickly order, physical therapy course, which has really, really helpful effects on his functional trajectory. However, as many of us experience after courses of physical therapy, he quits exercising and his functional and cognitive and social decline continue. This is sort of similar, in my opinion, to having Medicare cover a medication for a chronic disease for 2 months, and then after that, patients having to quit taking it because they can no longer afford it. As it turns out, this patient's very typical. Many of us struggle to follow up with exercises after a course of, physical therapy, but older adults who have frailty or gait impairments struggle the most. He represents more than 1 in 5 community dwelling older adults that struggle to leave their house and require assistance. So this is not a small fraction of our community dwelling older adults. And this means that while we have excellent community-based group exercise programming to sustain long-term healthy behavior, many of our patients can't get to them. And we don't really have a lot of resources for them to date. We also know from our prior work that at least in cross-section, older adults who are socially engaged are also more physically active. And this is a likely bidirectional relationship, and they're very closely linked. So all of these considerations really motivated our work. Over the last 6 years, we have been on really what I would call a journey to develop a program that helps frail older adults participate in exercise long-term from their home and to help them stay socially engaged at the same time. The result of all of this work has been this program we call Engage, which leverages Alexa devices as well as a care partner in dyad user group. The Engage program does use a platform that was created by our industry partner, which has 3 portals. There's a website and mobile app and the smart speaker. We customize our content for use on the Alexa device specifically. It's the only smart speaker that has options that have a tablet-sized screen. So we specifically use the Echo Show or a Fire tablet, which enable a visual component to our intervention. The care partners of the older adults primarily interface with the website or mobile app. And I'd like to walk through that experience with you now. So the older adult user primarily interfaces with this Alexa Show. The Alexa device actually delivers the audio and visual rehab instructions for a daily tailored exercise routine composed of strength, balance, and flexibility exercises that come from the NIA Go for Life program, which is an evidence-based exercise program intended for older adults to do in their home with home equipment. Nothing fancy to complete those exercises. So older adults will activate the program on the Alexa by saying something like, Alexa, start Engage exercise. And as soon as the program is opened, Alexa will read any new motivating messages that have been sent by their care partner. For example, I would open the program and read a message from my daughter who said, great job, Mom, doing exercises yesterday. Can't wait to see you this weekend. Alexa then guides the older adult through a daily routine of strength, balance, and flexibility exercises that include audio instructions, visual pictures, and jazzy music that differs with each exercise. I mentioned that the exercise content comes from the Go for Life program. We currently have 2 alternating routines that cover different muscles each day to avoid overuse. But they cover all of the major muscle groups. So they will experience strength in all important areas for older adult function maintenance. The program also uniquely has a built-in level of difficulty question that the users complete at the end of each exercise. Based on the level of difficulty rating, the program will auto-adjust how many repetitions they ask the older adult user to complete. So for example, if they rated a particular exercise too easy 3 times in a row, then Alexa would ask them to do more repetitions the next time the exercise was introduced. Therefore, the program helps to sustain growth over time. The caregiver users primarily interface with the mobile app and website. And here they are able to see and monitor the program that's being recommended for that day and to detect when one of those exercises has been completed. They also receive daily emails with summaries of the exercise completion, as well as any exercises that have been rated too difficult by their older adult partner. And this is sort of a built-in safety feature to allow care partners to passively monitor their older adult. The emails also prompt the care partner to send encouraging messages over the app or website, which are then read out loud on the Alexa device for the older adults to maintain kind of socially engaged and also motivated. Because we partnered with this industry partner, we also collect data on their platform, which is HIPAA approved and allows us to monitor individual utilization. So I mentioned this has been a journey. This has really been a long journey. This is a program that's been developed through participatory design, as the last couple of speakers have been discussing, and very relevant to this work as well. We created Engage through this co-design process, and we started with our concept, which we discussed with over 40 different stakeholders in informal interviews, which then guided the development of wireframes, which were static images of potential content and functionality that we put in front of 8 older adult and caregiver dyads in focus groups. All the focus groups have been minority older adults from our neighborhoods around the University of Chicago. This feedback then informed an in-lab demonstration, which we again put in front of older adult and caregiver dyads. Again, minority users, this time all were diabetes patients. And then that was used to inform an in-home full experience, which we tested in a feasibility study in 2019 to collect additional data, which I'll tell you more about shortly. I just wanted to point out that, you know, the Chicago Diabetes Center for Translational Research funded our second focus group, which really was a pivotal point in our design. It allowed us to partner with our industry partner and really enable the build of an entire experience, and to collect enough data to then go on to get another pilot, a larger pilot award that allowed us to do the usability study. So it was a really major turning point in our trajectory. So a little bit more about the in-home feasibility studies specifically. We paired with an independent living building, part of a transitional care building on the north side of Chicago. And we specifically chose the building because they were already a test bed for the Alexa for Business platform supported by Amazon. So 150 of their independent units had Alexa devices in them already, and the older adults were familiar with using it. So we didn't have to overcome that barrier. We could strictly focus on getting feedback on the experience of this program. So older adults were over 65. They all had unlimited Wi-Fi access. We did exclude people with moderate to severe dementia or contraindications, severe contraindications to activity, but we encourage people who were homebound to participate and include one of our participants was wheelchair bound. Care partners were self-identified by the older adult as a trusting and meaningful social relationship, and they just had to have unlimited Wi-Fi and feel comfortable using web browsers and apps. Just briefly, our timeline for the study, I wanted to point out that we included, on-site setup for the older adults and care partners. We included a 2-week run-in phase where we kind of we were able to troubleshoot a lot of glitches in programming and making sure that older adults had connections to their Wi-Fi, all before doing the 10-week intervention phase. And I think that was absolutely essential for this study to work well. We also included a 1-800 hotline number that allowed the participants to call and reach an individual person, not an automated message, should they have any difficulty. And that was also very essential. So the intervention for the older adults was just to complete this Alexa-based program using one of these 2 exercises routines, and they were alternated for them. All the older adults were given an Alexa show as well as a Fire tablet so they could select which device they wanted to use, and they were given some tennis balls and exercise bands, but very low equipment otherwise for the exercises. And the intervention for the care partner was to just check their email to see the progress, check in periodically on the website or app to see how frequently people were completing the exercises every day, and then send at will these encouraging messages, which were again prompted via the email. Just a brief look at the demographics. This is a really important piece, I think, to the story, is that our older adults in this study were not like our target users. They did fit the age range between 69 and 84. 4 of our 10 older adults enrolled in this study were 84. Most were female, all were college educated, most had decent income. They were all tech savvy at baseline, and many of them had a baseline exercise program already. So it kind of limited the ability for us to impact functional outcomes, but we'll see how that played out here shortly. And then of our caregivers that were enrolled, we were very shocked by the heterogeneity of this group. We anticipated a lot of children. We did not get that. Our 10 older adults identified friends, children, staff, even one person selected a spouse with whom they lived to be their care partner. So over the 10-week intervention phase, we saw on average that our participants completed 3 full 25 to 35-minute routines every week, which met the CDC guidelines for strength training for older adults. And that meant they completed about 25 individual exercises per week every week across the 10 weeks. However, if you look at individual users, you can see we had some super users and then we had some not so super users. So there was a little bit of heterogeneity in that as well. As for our outcomes, we were, again, very underpowered for any we weren't powered for any of these functional outcomes. So we were totally surprised to see a significant change in chair stand 5-repeated chair stand performance among the 9 users that were able to complete it, because we had 1 wheelchair-bound participant, and we actually had a trend towards improvement in grip strength. Everyone had a very, very brisk gait speed at baseline and a semi-tandem and side-by-side balance, so we didn't see any change there. A little trend towards movement in tandem balance, but probably not clinically meaningful. We then followed our intervention phase with qualitative interviews in focus groups, which I don't have time to go into in a great amount of detail, but just to mention how very, very helpful this feedback was to get the nuances of the user experience, all of the features that the participants liked and some that they found cumbersome or difficult that we can now refine and make it even easier for older adults. And I think the other very meaningful part of these qualitative interviews was getting the real life experience perceived benefits that we could not possibly capture with our functional quantitative measures. So for example, this one woman reported this great story in which she was having lunch with her sister who was 9 years younger than her, who couldn't open a pickle jar. She was able to successfully do it really quickly and was very thrilled with her new strength. So I think, we learned a lot of lessons through this 6-year process. And one is that tech can be adapted to older adults, but it takes a really long process. And we should never expect older adults to adapt to technology. We should always adapt the technology to them. So as others have mentioned, this is a critical process to ensure a meaningful experience, and we're still in the middle of that process. There were a lot of great feasibility lessons learned here that will inform a larger trial. And we're now looking towards piloting this in a group that has more disability or functional impairment, and more like the target user groups that we're hoping to support. Scalability, of course, in all these situations is a real issue that we're all facing. I think the other speakers are too, so we can all put our heads together and come up with some options there. Just shout out to the rest of my team and all of the folks who supported our feasibility study. And I am happy to take some questions.
Thank you, Megan. That was inspiring. I think we have time only for one question, and it comes from Amisha Walia. Do you have data on the time and effort in older adults being able to even access and or use the Alexa technology? Did it require research assistant or time to help? And this obviously has implications for the widespread scalability of this technology.
Yes. So do we have data on the time and effort in older adults being able to even access or use the technology? Well, in this case, again, we went into a group who was already Alexa friendly. And so I think that was a huge hurdle that we just eliminated for ourselves by doing that. All of our older adult users, nine of the users did the program on their own. And then we can also get from the platform the number of times that they logged into the program and how long they participated in those exercises. So we can see that as well. There was one user who had mild cognitive impairment, and we learned through qualitative interviews that her care partner actually did the exercises with her every day. So he operated the program and then they did it together. So another potential value for supporting a care partner in caregiving and empowering them, and then also alleviating that kind of tech use hurdle for otherwise tech illiterate older adults.
Thank you, Megan. And why don't we just take a moment and give a virtual applause to all of our speakers in this sort of round of short talks before our final keynote speaker. So that was a really, I would say, impressive in terms of the consistency and rigor and pushing the envelope in each of the areas of research that the various investigators were describing. So very impressive. So I have the pleasure of introducing our final keynote speaker. It's sad to see Diabetes Day ending, but we're going to end on a high note. So our final speaker is Lou Phillipson, who is the James C. Tyree Professor for Diabetes Research and Care at the University of Chicago. Dr. Phillipson is an endocrinologist and a leading world authority on diabetes. His clinical interests include type 1 diabetes, complicated type 2 diabetes, monogenic diabetes, and hypoglycemia. He's a very busy clinician on top of being an investigator. He serves as the founding director of the Culver Diabetes Center, which has become a leading center for diabetes research and care. And for more than 25 years, he's tirelessly explored the biophysical, molecular, and genetic aspects of insulin secretion and the genetics of diabetes. He and his colleagues discovered rare insulin gene mutations that produce beta cell ER stress and in turn cause neonatal diabetes. In his current research, he and colleagues are among the nation's leading experts on monogenic diabetes, following more than 1,000 patients diagnosed with monogenic diabetes, otherwise called MODI, including over 150 with neonatal diabetes. He's played a leadership role in multiple important platforms for diabetes, including serving as president of medicine and science for the American Diabetes Association in 2019, and he was past regional president in Chicago, Northern Illinois for the ADA as well. I just want to briefly describe his long list of honors, which is extremely impressive. He's a recipient of multiple awards from the ADA Research, American Diabetes Association, the National Disease Research Interchange, and he was also the 2011 recipient of the Samuel Eichhold Memorial Award for contributions in diabetes by the American College of Physicians, and he's a laureate of the state of Illinois' Order of Lincoln in 2018. And I want to just finally end with an honor that we want to add to this long list. We are happy to announce that Dr. Phillipson is the 2021 recipient of the Donald Steiner Award for Outstanding Achievement in Diabetes Research. Dr. Phillipson.
Well, thank you for that introduction, and I want to thank Graham and the organizing committee for the opportunity for this very meaningful award in memory of my teacher, friend, and colleague, Don Steiner. What I'm going to talk about in the next few minutes is the path I and my many colleagues have taken over the last few years, a little over 15 years, as we have gone from neonatal and monogenic diabetes to include atypical diabetes of all kinds, monogenic autoimmune diabetes, and now also participating in efforts to use the lessons we have learned for a new international effort for precision medicine for all kinds of diabetes. Let me start by saying I have no disclosures related to the topics of this talk. And I do want to immediately recognize many of the current and recent members of our team, including Graham at the top left and Don, who's now gone almost 7 years, Siri Greeley, Rochelle Naylor, and so many of our other team members, some of whom have already moved on, some of whom are fellows and faculty, but without them involved, we wouldn't have the inspiration and energy to make any of this happen. I wanted to start by giving you a sense of the trajectory here, that this concept of monogenic diabetes really started a long time ago, and Stephen Fayens and his colleagues meticulously organized some of the initial studies on families they recognized. But even before 1987, some people have argued that cases of atypical diabetes have been described for really hundreds of years. But it wasn't really until that series of papers beginning in 1987 with the Fiennes group that the things really get started for the modern era. And then you can see on this study that Graham's name is in almost every line, and when it isn't, it probably should be. The Modi linkage studies, starting with publications in 1988, the glucokinase work with Philippe Frigel and others, but in Graham's lab around 93. The idea that sulfonylureas can treat some forms of Modi that same year. Some of the people that I really grew up with, Maria Byrne, Jeppe Stouris, Marcus Stoffel, and other people in Graham's lab, which were so impactful for my career. And then you can see I really entered the picture around 94, was my first paper with Don, and Graham and Susumu Seno were critical parts of that effort when I started out in those areas, studying potassium channels and to some extent calcium channels in the insulin secreting cells and elsewhere. And this brings us all the way up to, there'll be some resonances in 1998 to 2000 when Pontaglio and others in Paris also worked with Graham to look at the glucose disposal threshold, and that'll be the SGLT2 connection with HNF1 alpha. More about neonatal diabetes with the Nolsted group. And then this shows where, really things took off. 2005, when Siri and other people helped with our first KCNJ11 participant, more soon, and 2007, the first family with insulin gene mutations that caused actual diabetes. So just a few words about each one. I'm not going to spend a lot of time. Many of you are intimately familiar with this early work of ours. So we met Lily in 2005 or so, 2006, and the story is now recorded in a full-length video movie I'll show you in a moment. But through happenstance, I met her father. Graham was able to organize sequencing. Soon after that, we identified a KCNJ11 mutation, and we were able to help Lily get off insulin, which was a very big deal. The family was exceedingly grateful and wanted the world to know more about it. So by 2015, they had made a full-length movie, which is now available on Amazon Prime, Vimeo, Facebook, YouTube. There's a Facebook group called Journey to a Miracle, Freedom from Insulin. It's won awards all over the world. So wonderful to see Andrew Hattersley striding the moor, and people like Frances Ashcroft, who was key to understanding KATP channel activity, getting very emotional about her role in this work. What the basis of all of this was sort of images that are now sort of burned into many of our collective memories through work of Susumu Seno and the Bryans, many of their collaborators and colleagues on the one hand, and Anna Gloin, Andrew Hattersley, Frances Ashcroft, and many other people on the other hand. An image was formed of how KATP channels were critical for regulating insulin secretion in the beta cell. You can see them on the bottom left, that they need to close through metabolism, regulated activities in order for insulin secretion to happen. And mutations in those channels can cause either low blood sugar or high blood sugar. But in the case of causing high blood sugar, the channels are locked open, and then this other miracle that was discovered, the sulfonylureas, in fact, exactly block the channel. So much of that activity then became the key to what we're doing now, and eventually Siri's suggestion that we ought to think about making this, a thing and having a registry, and that's in fact what we did. This diagram I've shown many times, and the rest of our group has as well, from Larry Chan, who was at Baylor at the time, trying to show that there was importance for all kinds of diabetes by understanding the monogenic diabetes genes. And that continues to be a theme, as you'll see by the end of the lecture, including now in the middle of the lecture. I'll mention the newest member of this family, SCAP2, as one of the examples of autoimmune diabetes in the monogenic area. So I think many of you know now that we think about polygenic and monogenic forms, and then more recently this notion has been embedded in us too about what's typical and atypical. I usually mention at this point that I don't understand what's typical, and in fact the more people that I see with diabetes over in this sort of late part of my career, there's almost no one who's typical anymore. So that really becomes an interesting thing that makes all of this in a way worthwhile. Recent evidence from groups in Sweden and India and at the Mass General, Miriam Butler and Jose Flores have shown that type 2 diabetes really can be clustered, and that idea, based on data, I think comes out quite a bit of what Graham started when he worked with Steve about the monogenic forms of diabetes. But we're still talking about, relatively uncommon, not rare. Everyone sees people with monogenic diabetes, they just don't not always know it. This was the first family that Dr. Fyans put together in Michigan, the RW pedigree. You recall from the timeline, he was studying this family really quite strongly by the 1980s. And a young Polanski and Bell teamed up with Steve, with Nancy Cox and many others to first try to identify the location, look at linkage, then chromosome studies, and then finally the gene itself and multiple mutations. But this family, with all the black circles and squares being folks with diabetes, was really the strongest evidence that dominant inheritance of diabetes genes was actually quite important. I'm going to show you a couple of cases, just very briefly, cases that some of you have seen actually many times now. This is a woman we met a few years ago who we continue to follow and continues to be extremely interesting. That she was 58 when she first came to our attention. She had diabetes at age 19. At the time, she was thin, had every kind of diabetes, initially diet controlled, fluctuating diagnoses, gestational type 1, then type 2, and then type 1 again, was on an insulin pump, and she gained something like 100 pounds and had a BMI of 40 when her endocrinologist looked at her pedigree, and this was redone recently by Tiana from our registry. You can see the reddish orangish arrow pointing to our main subject, and you can see that both of her sons and many of her other family members also had diabetes, and this also helped justify the genetic sequencing that led to the diagnosis of MODY3 or HNF1 alpha. So when that happened, sulfonylureas were started, we were able to withdraw her insulin. She had lost over 70 pounds, and interestingly, her children were initially ambivalent about genetic testing. They had a strong identity as having type 1 diabetes. Eventually, one of them was tested, and then the other, but none of the children, their children, so her grandchildren, have been tested. And also interestingly, last year, this woman had an episode of severe diabetic ketoacidosis, which was euglycemic DKA, after her well-meaning physician started an SGLT2 inhibitor. And this was one of our concerns, that people starting these drugs, since they already have a decreased SGLT2 expression, might have complications like this from these drugs. So this is something we are looking at to this day. Just to remind folks what a transcription factor is, this is from a review article that Jose Flores and his team put together a few years ago. So the idea is that HNF1 alpha, 4 alpha, even 1 beta have a similar structure, that they bind DNA, they activate other proteins, but that mutations, especially in the DNA binding and transactivation domain, can render them ineffective. Even also, Graham probably was the first one to show that there are other sorts of mutations. There are coding errors, there's errors of splicing and other sorts of things besides simply substitutions. So this map was made in 2017 by one of our students, Swathi Balaji, who tried to put together everything we knew at that moment. And you can see all those red circles are variants in the sequence. Most of them cause MODY3 diabetes, but not all. There are some here that have turned out to be benign variants or partial variants, and we do have a sense that depending on where the variant is and the kind of variation, there might be alterations in the time of onset, but that has not has not been firm. There are some papers suggesting that, and there's always a question to this day of whether everything is haploinsufficiency or some of these are related to dominant negative effects. I mentioned a few minutes ago that HNF1 alpha controls the expression of SGLT2, and those ideas really came out of work from the Pontaglio group in Paris, working with Graham around 2000. And this is the diagram of how the renal tubule works, with SGLT shown there at 1 and then above SGLT2, and they account for the reabsorption of glucose to a very large extent, 90%. So it turns out that HNF1 alpha directly causes SGLT2 gene expression, and there is an early appearance of glucose in the urine of these folks, which sometimes leads to their diagnosis even as children, just from a sports physical. But Andrew Hattersley and us have said that maybe giving people with HNF1 alpha mutations and even maybe HNF4 alpha mutations are potentially dangerous, and having euglycemic DKA or hypotension are the two things we're worried about. So we are warning against that, but there's no literature yet. I just wanted to show one case, and you can see on the slide, this is a glucokinase mutation case, also one of the first genes that Graham and others put on the map as causing diabetes. So this fellow, or at least hyperglycemia. So the arrow points to our subject who was diagnosed with diabetes at age 26, but as typical with all of these folks, his A1C was never that high, his BMI was on the low side, and yet even though he had negative tests and positive insulin secretion, he was on insulin for 13 years by the time we saw him. Tiana also put together this updated pedigree of this family, which was a little difficult because some were in California, some were in Europe, but you can see again this very strong notion that there is dominant inheritance here, and all of the family members are with hyperglycemia have a similar phenotype. So back 20 years ago, Graham and Ken and others put together this map, which is still accurate, although details have been added, showing that the glucokinase enzyme, which is critical on the left side of the screen, is critical for regulating insulin secretion in a lot of different ways. A map of glucokinase is shown on the right. So this is the folding diagram of the protein with the classic butterfly wing shape, and the middle of of those wings are the active sites. So most of the mutations, as you can see here in another map that Swati Balaji made a few years ago, a lot of the mutations seem to be randomly distributed, but when you fold it up in 3-space, a great deal of them are right in the active site, affecting either binding or function, enzymatic function of the enzyme. But some of the mutations are clearly way out at one end or the other, and so to this day, the actual role of some of those distal mutations in other functions of the enzyme remains to be studied. It's something that being actively looked at by Anna Gloin in her group now at Stanford. The basic concept is simply this, is sort of physiology of diabetes, that normal folks have an insulin secretion function which recapitulates the glucose phosphorylation capacity of the enzyme so that it's linear in the range right around 100 milligrams per deciliter, which is what the normal blood sugar is. MODY2 is shifted to the right, so insulin secretion happens, but a little sluggish. And then in those people who are unfortunate to have homozygous mutations, they essentially have permanent neonatal diabetes. And interestingly, this slide from Bill Winter resonates because Bill is now running the lab for our Radiant grant that I'll talk about in a few minutes. But our patient, or our subject, was actually a rocket scientist, and he was very interested in categorizing his blood sugar. And you can see in the red, he has his blood sugars before, and in the blue after, he simply took off his insulin pump and just went on no insulin anymore. The only thing that really happened was he had fewer low blood sugars, and an early CGM back in 2015 showed basically no change before and after insulin. We also know that complications did not happen. And Andrew Hattersley and his group and some others have repeatedly now published that even though the A1C is as high as the low 7s, these folks just do not get complications of diabetes. It's very hard for some of our colleagues to grasp that and insist on treating them, even though the outcomes are benign. And so this is something we're still working on. But these are some of the take-home points from the glucokinase mutations, that the simple clinical criteria, as Andrew Hattersley likes to say, of stable elevated fasting glucose, mild, stable A1C elevations, usually a family history that's been confusing to their doctors, almost always antibody negative, usually non-obese. These are the things that can tell us who might be the almost 1 in 1,000 people with GCK mutations in the United States. Now, I just wanted to spend a minute on the insulin mutation story because that continues to be something of intense interest. This family was identified when the young woman at the time came to my clinic and said that she had an unusual form of diabetes that occurred when she was very young. She had diabetes at 3 months of age, and there you see her family history. We're able to recruit them into our study in the early days, and again, Graham and his group was able to identify a mutation. That summer, we shared it with the Hattersley group, and that's why there are so many authors there, but Julie Stoy, who was a fellow in Graham's lab and continues to work with us and work on insulin gene mutations, was a key person who helped to drive some of this. And you can see that Don Steiner was also critical in this work. So this led to the reevaluation of insulin mutations in either neonatal diabetes or later onset diabetes, and yet another paper is coming out on what Peter Arvan and Michael Weiss have been calling MIDI, so insulin-dependent sort of MODI kinds of diabetes, or monogenic insulin diabetes, not a term I favor. But what's interesting is that the grandchildren of my patient have developed pancreatitis, and Dr. Greeley and his students have been all over that, and I'll leave for them to tell that story another time because it's extremely interesting. What does the effect of insulin gene mutations do? Well, you probably destroy the stability of the RNA, but there are other possibilities, including making partial proteins that cause ER stress and destroy the beta cell. And in fact, the insulin secreting cells are extremely sensitive to ER stress, which we'll review in a moment. But Don and Graham and Hong and Siri were key and continue to be key in understanding these mutations. This is a figure that Hong updated a couple of years ago, showing in black dots those mutations in the insulin gene that cause neonatal diabetes, and those in purple that can cause a MODI-like syndrome as well. So this was Graham's thinking that became part of a paper, and Graham and Don, that Don also wrote with us a few years before he passed away, that insulin clearly is important in the beta cell. Not that that was a surprise, but I don't think it had been thought of in quite this way, that given that it's 10% of the total protein and 50% more of the total protein synthesis, it means that there's 1 million molecules or so of insulin being made per minute when it's stimulated, which means 4 million molecules of reactive oxygen species or hydrogen peroxide are generated during the formation of the 3 disulfide bonds in every molecule of proinsulin. So this by itself induces ER stress, and while insulin gene mutations are a microcosm, it's part of the entire picture of diabetes and needing to make more insulin. So this diagram, recently updated based on original figures from Graham and Ken almost 20 years ago, tries to group the beta cell related monogenic diabetes into particular categories of either gene expression, ER stress. You can see exocrine pancreas disorders, autoimmunity, which we now need to update, and a few other things. It does not include monogenic disorders of insulin action, which I will not discuss in this talk. This is a summary of the last 15 years or so of our registry. We now have something like 4,000 participants, of which over 1,000 have a known cause of diabetes. The overwhelming majority have glucokinase mutations. You can see there we're around 400. HNF1 alpha MODY 3 is the runner-up, and then everything else is a little bit less. So we are continuing this study. We think there's a lot more that still needs to be learned, with now multiple groups across the country and the world being interested. There's some of the more rarer forms are now possible to be studied. So in fact, when we started, we didn't really know anyone else who was doing this sort of thing. A couple of groups maybe in the United States, aside from the several groups in Europe. Now we have a long list of groups that are very actively looking at monogenic and atypical diabetes, and it's been very rewarding to see the growth in interest and the understanding of how important this area is. And at the same time, there's been an explosion in laboratories that will do sequencing instead of just one or two or just Graham's lab. Now people have numerous choices, and the price of sequencing is plummeting down to as little as $250 and even $100 or so out of pocket for many patients. Now, I mentioned we're still finding new entities, and this was yet another patient who walked into my clinic. This young lady had no family history, but still was intensely interesting, unfortunately for her, with a combination of type 1 diabetes, thyroiditis, multiple other sorts of autoantibodies, looking like a mixed connective tissue picture, and even hemolytic anemia, exercise-induced anaphylaxis, very bad for a runner, other multiple food allergies. So I still see her to this day, but we thought, all right, we have possible interesting collaborations. We'll continue her clinical characterization, but also we had a collaboration with Mark Anderson, Mike German, Cliff Lowell, and a bunch of other folks at UCSF, and they sorted out that she has a mutation in a gene called SCAP2. And you can see in what now has become a very familiar comparison across species from humans to zebrafish, that this particular glycine at 153 and this gene called SCAP2 is highly conserved, and yet our patient has an arginine, and both her parents, in fact, are wild type with the glycine. And you can see in this that SCAP2 has already been, this crystal structure has already been identified, and this mutation comes at a very key residue in a lipid binding loop. And what that does has now been partially sorted out. So what is SCAP2? Well, it's a Sark kinase associated phosphoprotein. It's been described as an adapter protein, which helps translate a signal from the cell membrane, shown at the bottom, to the other side of the cell, or anywhere else on the cell membrane for that matter, to integrin signaling. So basically what happens is either a chemokine can bind to a receptor that activates a phosphorylation cascade, proteins like WASP and ERK are recruited, and the integrin ligands are then activated, and in this case mostly in macrophages. Now in our case, it looks like the SCAP2 with the arginine instead of a glycine results in what our colleagues have called inside-out signaling. So it just means that SCAP2 is turned on in the absence of a external signal to the cell membrane, and that seems to be bad. So it results in continuously active macrophages, constant integrin responses, enhanced cellular migration, and cell morphology changes. And a couple of things come out of that. One is, with all of this, how does it cause type 1 diabetes? So we're not entirely sure about that, but there are already mice with this knock-in variant that are being studied, and early data does look like they have the beginnings of increased incidence of type 1 diabetes. It's possible also there's a druggable target. Our subject is very hopeful that there may be some specific treatment for all of the different things that are going on, some of which may in fact be halted or even reversible. This has been a very amazing study. So with all of these things, when the NIH put together a RFA several years ago for a new kind of grant opportunity in a study looking at atypical diabetes, we jumped at the chance. We were just at that time working on a book with Boris Drazen and Janet McGill that cleverly was called Atypical Diabetes, a series of case reports that Boris helped recruit and organize on all kinds of atypical diabetes. And the structure that we proposed for this RFA was, in fact, what you see here is how it's become to this day, with a steering committee and various cores to try to evaluate people who were referred to us. At this point, the study is well underway, thanks to teams across the country that I'll mention. And I put Lisa's picture there, Lisa Letourneau, because she's really been the heart and soul of making all of this happen from the Chicago side. This is from the Radiant Atypical Diabetes website, that we are interested in discovery, to evaluate testing procedures, to understand once we get some genetics, some people may or may not have a clear genetic aspect to their diabetes. Can we use this to better diagnose and treat people who have whatever typical diabetes might be? So that's how that website is working, and we're well on our way. After writing the grant, the NIDDK folks decided they would fund 2 of them. So then there was a kind of a shotgun wedding, and our group, which was myself and Jose Flores at the Mass General, with the group of Ashok Balasubramanian and Jeff Krischer at Houston and in Florida, were awarded each a grant. And yet our efforts were then combined with Christine Lee and Alan Leshik as program officers at the NIDDK. Eventually, we had 14 sites established across the country. So these are all the sites that are critical, with Jeff Krischer at Florida being the data coordinating center. At this point, you can see that it's an amazing effort. These are just the people in one committee, and there are multiple committees. It's one of the largest committees, but it is the adjudication committee that's helping to identify those cases that will move on or that are otherwise complicated. It's been an extraordinary effort to get to know the people here that I didn't know already. The basic exclusion criteria are shown here. We're looking for people who are not whatever usual might be. So that turns out to be difficult to describe, and of course overlaps with monogenic and MODY kinds of diabetes. So oftentimes we're asking that people get tested for the known monogenic diabetes or Wolfram syndrome, lipodystrophies, and so on. So this is how we started the process, and this is the very simple flow diagram that starts with recruiting people for a stage 1 online consent. So this is done very well in the time of COVID because the participants don't have to be seen in person. Once the questionnaire is done and an autoantibody test is done, those people who are negative for antibodies and actually have diabetes and seem to be atypical go to adjudication committee, and then you see stage 2 is whole genome sequencing, and stage 3 would be some kinds of physiological testing in order then for additional phenotyping to be done if necessary. As of the beginning of May, we had already consented or begun to look at 473 individuals. So in only a few months, we've really blown through all of our yearly targets. And you can see that we're over sort of 200 people who are ready for stage 2, and then close to 100 have already gone through stage 2. So we're moving through all of these things. So this would be what happens after stage 2. So these numbers are very low because we just haven't gotten there. But some of this will involve genetic testing and RNA-seq, metabolomics, and physiological structures. So what's the status? We're soon to get our first genetic data, both whole genome and mitochondrial DNA. Interestingly, about 20% of the subjects are so far antibody positive, meaning we're for the most part calling them type 1. And What we found, though, is that we need additional approaches to better reach a diverse population to discover and characterize diabetes subtypes. And we're hoping that this will provide a resource and some insight, although right now it's too soon to tell. So let me spend the last couple of minutes on this precision medicine idea. I've been fortunate enough over the last couple of years to be part of this international effort, really started by Paul Franks, who has been at Lund and is now moving to the foundation of Novo Nordisk. Steve Rich at the University of Virginia, who is known for his work in type 1 diabetes genetics. And not shown there is Will Cefalu, who's now head of the diabetes branch at NIDDK, who really was the other driving force with Paul and Steve to get this going. I joined when Will left the ADA and joined the NIDDK. And then John Nolan, who past president of the ESD, who's been very involved with the Steno Clinic and is now in Dublin. It has really been amazing in getting meetings together and doing some other organizing. And now we brought in Bob Eckel, who was last year's ADA president, and Bob Gabe, who's the current chief medical officer. So the structure of this is to have an oversight committee, a steering committee, various advisors. And the first papers came out from this group last year. And you can see the group with many familiar names to those of you in the diabetes genetics space. And one of the issues is that this is not about genetics. So even though that's been a theme, and you can see these sort of founding opinion papers with, again, Paul Franks and Andrew Hattersley and his group, the idea of all of this is that specific treatments can be targeted to groups of individuals with specific features. Now, I took this slide from that Fittipaldi had made in his 2018 paper and added genetics to all of these categories because they were left out. The idea was that this ought not to be genetic-centric in its approach, but should include risk factors, natural history, everything you can see here, regulatory environment, approval, clinical translation studies, and importantly, patient feedback, acceptance, and participation. So while we're interested in all the various factors, and this is not necessarily a beta cell, but it's any cell. So to looking at biomarkers, these could be insulin secreting cells, that could be other cells that participate in glucose regulation or glucose action, but you can see drugs, vitamins, metabolites, extra environmental signals, and other aspects of the environment, including, I would have to say, stress and systemic racism. So the idea here is that we have both precision and personalized aspects. Precision being exact and accurate in terms of prediction and definition in groups, but personalized being what do we do for this particular person. And this is basically the definitions that we put into that very first paper from last year from these groups, where we want the precision underlying the ideas to then be modified for each individual person. The concepts are divided into these areas: diagnostics, prevention, treatment, prognostics, and monitoring, in no particular order. But this was one idea of how we might move to precision diagnostics, from epidemiological evaluation, some probability measures, which could include genetic probability scores, diagnostic testing, which I would suggest should include autoantibodies in every case. And then that would lead to subclassification, even perhaps based on C-peptide testing, which may one day then enter the standard of care in the clinical arena. But other things, prevention, therapeutics, treatment, monitoring, ongoing, sort of this fourth dimension of the medical record in a kind of a dashboard idea, some of these things are what we're thinking about going forward. Prognostics, who will get various sorts of complications? How can we rank them and give the patients warning that this may be a problem? So where we are in the timeline, we're somewhere between phase 2 and planning the phase 3 stage. We're trying to put together another set of committee reports on the best evidence for all of these different areas. We already had another symposium just a few weeks ago that had over actually 3,000 members were part of that symposium, and some of that will be published and online through the American Diabetes Association website. And then the idea is to inform RFAs going forward about how to do this. So how did we get from monogenic forms to personalized diabetes medicine? Well, a lot of the same principles apply, but the most important thing that I still can teach is to take a careful family history. Once you've done that, you can understand what might be involved through the environment or through genetics or both. But occasionally, as you saw in our SCAP2 patient, some folks will not have a family history, and that also, it doesn't mean that genetics are not important. I just want to thank my colleagues, supporters, teachers who've passed away, who I think about constantly, and all of the folks who have helped us, so many people, Graham, of course, and Siri Greeley, Rochelle Naylor, Lisa Letourneau, Tiana Bowden, all of our students, fellows, nurses, project managers, Peggy Hassenauer in particular, who helps just grow and support all of our team in the growing Kohler Diabetes Center. And of course, my lovely wife, Lynn, and my children, Ben, Joe, and Mira, who continue to support me and give me a sense of humility all the time. So thanks to all of our participants and our families, and I hope there's time to take some questions. Thanks.
Thank you, Lou, for that inspiring talk. I'll invite Raghu also to join us as well in the question and answer period. There are two questions, both from Richard Levy. I think they basically boil down to, should we be doing monogenic screening? Should we be doing genetic screening when we're thinking about prescribing drugs in type 2 diabetes? And he specifically called the concern about SGLT2 inhibitors.
Yeah, so I don't think there's enough frequency yet to screen everybody with type 2 diabetes. I think part of what we're recommending is that by taking a family history, knowing onset, and understanding the person in front of you, you can decide if this person might be high enough risk for that to be an issue. But some of the measures we're advocating, looking at antibodies to be sure someone doesn't have adult onset type 1, which is most often missed, for example, or other sort of more rare forms. I mean, that might lead to testing, but not yet.
Thank you. And I really actually appreciate your commentary about the difference between precision and personalization, because that actually combines almost everything that's been discussed today. We started today talking about food insecurity and different ways of addressing food insecurity. There are discussions around people at different stages of aging, different stage of frailty, physical functioning, or people with the digital divide as well. And acknowledging all of those factors while trying to decide on a treatment regimen for somebody is all part of personalization. And embedded within that is what you're thinking. That's where genetics fits in.
Absolutely. I mean, as I said, for the personalized medicine, genetics is just one component, which it may not even play in much of a role. I mean, one of the things that our friend Dr. Bella Subramanian from Houston reminds us is that this RADIANT study may identify people with environmental causes of diabetes, and we know that stress and structural determinants of health can affect cortisol. I mean, there are pathways that are biologic that also can affect physiology. So I think these things are eminently related. I think from the very first talk today, we understand that if you can't have a reliable roof over your head and food on the table, it's very hard to go to your doctor and do regular exercise and all those other things. So we have very basic issues that now can be addressed in a lot of ways, but we're hoping we can put it together for these sorts of studies in the future.
actually, Lou, I noticed that Roland, our good friend Roland at Vanderbilt, has a question for you, and I'll read it for you. Is it clear that MODY factors are only developing adult defects, or could be manifested earlier during development?
Oh, absolutely, can be earlier in development. I mean, one of the things that we're looking at right now is sort of the interaction, for example, between the acinar pancreas and the endocrine pancreas, and some of the genes that affect one will affect the other. Without stealing Siri's thunder and his wonderful student, what is possible, and we see this as another example outside of the one Siri's looking at, but Paul Nolsted in Bergen, Norway, has been very interested in the CEL gene, a carboxy ester, maybe it's a lyase, that causes exocrine pancreas disease and pancreatitis, also causing diabetes. So I think that the back and forth is very important. I think what Roland is interested in particular, for example, is some of the genes he's been interested in, the MAFs, when there was developmental issues, those issues can happen extremely early. One of the cases that we heard about just this week was a child with a GATA6 mutation. So Siri and Andrew Hattersley and others have been very interested in these kids. They have a range of developmental defects that can come later on with an endocrine insufficiency. Early on, they have pancreatic developmental issues all the way to pancreatic agenesis. So there's a range of issues that can happen early on, especially when there's transcription factor diabetes involved.
And I've also noticed that Miriam Knopf from Brussels has joined us as well, which is fantastic. And she has a question as well. We've looked at where patients with monogenic diabetes fall in the 5 clusters described by Emma Ahlquist et al., and unexpectedly found them more or less spread across the clusters. Have you done a similar exercise in your fantastic and well-characterized cohort, and can you comment on this?
So actually we haven't. I mean, so great to hear from her, and a good evening in Brussels, but so what should I say? I mean, some of the variants are, of course, VUSs that we've seen. So we don't quite understand necessarily if these are pathologic or variants that may have limited impact. I think what we'll see in the RADIANT study is whether that comes to pass, whether in fact there are variants that are beta cell specific that affect insulin secretion. But at the end of the day, I mean, to quote Graham, I think again, it's all about the beta cell. And if you have a robust ability to make insulin, that person or organism is going to be able to overcome defects in insulin action. But at the same time, we work closely with people like Elif Oral in Michigan, who is extremely interested in the lipodystrophies, and we've seen overlap syndromes with partial mutations or partial functional mutations in the insulin receptor, for example, which also lead to a monogenic syndrome. So there's lots of things that we have yet to understand, lots of unknowns, working with other people to identify, the collection that is being accumulated. And right now, the unknowns are probably more interesting than the knowns, but we can study different things. But it's a great question.
And then one more question on the Q&A. What about the epigenetic regulation of all these genes? You want to comment on that, Lou?
Yeah, so what about the epigenetic? So the answer is we don't know much yet. One of the people we've been collaborating with is Jorge Ferrar, who's been very interested in promoter variants in many of these genes, and we've sent and he's analyzed some of the unknowns that we have. Otherwise, the model might be a situation Siri and I were discussing this week with our team, is the 6q24 mutations and our parental disomy mutations, where methylation is the whole ball game, and exactly how that may play in some of the other genes. I think we have sort of yet to be seen. There are some very interesting correlates of I could list all sorts of interesting things. Chromosome 17 mutations, for example, which wipe out many genes, including HNF1 beta. So you have a subset of diabetes with renal cysts, with also neurodevelopmental disease. So that's something that is getting increasing attention, and Rochelle Naylor is interested in that. As I say, a large number of issues, but no, I think the idea of epigenetic regulation of the beta cell specific genes is just really getting underway.
Yeah, exactly. Right.
What do you think, Raghu?
I think we've
had
hit
a good morning.
Yeah, we had a great day. Terrific talks from across the spectrum, from cells to society to behavior to you name it. It was fantastic, and it was great to see both junior and senior faculty present today.
I completely agree. It was despite the virtual format, it was really engaging.
Yeah. Well, we're gonna do this again next year, right, Albert? And I think do we have a date for next year?
I don't know. I don't know if Graham Bell will pipe up and say something, but
I don't think he can because he's not. But I
don't think he can.
I think we've got a mid-May date for next year, and we'll send it out, and hopefully we'll do it at least in person and virtually. So probably have some kind of a hybrid approach for next year, because clearly we've been able to include people from really around the world today, and I think that's been a huge advantage to this to the online forum.
That's right. Let's not lose that part. One side benefit of the pandemic. Well, thank you, everybody. This has been a fantastic Chicago Diabetes Day, very successful. And come back next year, and we'll see you again.